Good morning, everyone from Goroka Eastern Highlands. We are so excited that you are able to attend our 5th annual Virtual Symposium today. My name is Gwendalyn Vengiau, and I'll be co-hosting our symposium today. The Virtual Symposium program will include some fantastic keynote speakers and interesting sessions on climate change, health, and One Health system. This year, we will also have a wonderful session to pay tribute to late Emeritus Professor Michael Alpers. We will then have a short break, and then we have spotlights featuring research work from our upcoming researchers. And then the program will end with a session on COVID-19. It is now my great pleasure to introduce our Director of Papua New Guinea Institute of Medical Research, Professor William Pomat. Professor Pomat has served at the Institute as the Director since 2017. He has extensive knowledge on pneumococcal serology and immunology. During the COVID-19 pandemic, when there was so much uncertainty and panic, Professor Pomat provided much needed recommendation and advice to the government of Papua New Guinea to guide their response to COVID-19 pandemic. He is committed to ensure that the health of our fellow Papua New Guineans is improved through health and medical research. Thank you, Professor Pomat.
Thank you, Gwen. Good morning, everyone, and thank you very much for joining us for this virtual symposium. This morning, I have the pleasure of welcoming you all, both online and in person here at either at the Institute here in Goroka, in Port Moresby, in Madang, or elsewhere around Papua New Guinea where the IMR sites are based. And I want to welcome all of you. We particularly want to welcome our international guests who are online today, and hope that you will enjoy the presentations that will be provided today. This 5th virtual symposium has the theme Research Evidence for a Changing World, and it is an apt theme for us today because the world is indeed changing, and we are all witnesses to that. And as we see the changes in climate, its impact on the environment, on animals, on our own health, plus our own impact on the environment as well is part of what is creating the change. We begin today with 2 great speakers, keynote speakers that will pave the way for the rest of the sessions today. And I hope that you will sit back and enjoy those 2 presentations plus all the different presentations that will come. Now, can I now hand over to John, who will introduce you as well. John and I are co-chairs of the Buttressing Coalition, which aptly hosts this symposium and makes it funds this symposium for us to be able to host it for you. John?
Yeah, thanks, Willie. Can you hear me okay?
Yep.
Yeah, and thanks, Dr. Gwendalyn, and greetings to Dr. Isi and also Professor Isi and also Sir Isi, and also to keynotes, all the speakers and keynote speakers. It's great to see Dr. Donald from Fiji joining us, and also Dr. Lucas, and many others, and of course the PNG IMR team, which is the whole purpose of this arrangement, is to showcase and to share the information about the IMR team, which has been working so effectively. As Willie mentioned, I had the privilege of co-chairing the Buttressing Coalition over the last 5 years, and it's been a very fruitful time, I think, for the Buttressing Coalition to help in its endeavours to support the efforts of the PNGIMR. We do need to make sure that our institutional members do keep paying their membership fees, and they have continued to do so. And we really need to encourage more members and also more greater payments to continue. And have also been, over the last year, been working very hard to make sure we have a strong support for the efforts of the PNGIMR to establish itself as a key research institute within the Asia Pacific region, as it has done so and will continue to do so with our support. So it's this symposium, which is, as mentioned by Gwendalyn, in the 5th year, I think is a really a good sign of how we all work together, and it's also an opportunity for us to come together using this great technology. But ideally, we want to see each other more in person and keep encouraging the direct personal exchanges that are so crucial for our collaborative work. So I hand over. I don't know. I hand over to Sir Isi, or hand over back to Gwendalyn, or whatever. Anyway, my best wishes for an excellent symposium. Thank you.
Thank you, Professor Kaldor, for your address. Now, before I introduce our next speaker, I would like to please ask the attendees that if you have joined us from around the country or abroad, to introduce yourself on our chat and also send pictures using our WhatsApp number that they will be providing on the chat, or you can always post the pictures on our IMR Facebook page. Now it's truly my honor to introduce to you Professor Sir Isi Kevau. There's so much to say about Professor Sir Isi Kevau today, but I will focus on his expertise or more of his passion. Sir Isi Kevau is one of the only 2 cardiologists practicing in Papua New Guinea. Sir Isi is deeply passionate about improving heart health across the country. He is heavily involved in developing the next generations of Papua New Guinea doctors through medical training and education. As we reflect on our 50 years of independence, we would want to recognize his enormous contribution to the development of the country in the field of healthcare, medicine, and education. And here is Professor Sir Isi Kevau from Lamana in Port Moresby.
Thank you, Bada. That's the most we wait for. Thank you very much. So in the 800 languages in Papua New Guinea, I love the Motu language. All sorts of jokes will come out of that, but not today. Share those here until 5 o'clock in the afternoon. And I would firstly like to say thank you to the Australian High Commission and the Buttressing Coalition Group for making this opportunity available. Let's give them a right hand. Thank you for that. You know, the way things have evolved over the Pacific and including Papua New Guinea, I look back to the 1960s. In the 1960s and before the 1960s, Papua New Guinean doctors were trained in a little country called Fiji. In the 1940s, 1950s, Fiji was where Papua New Guinean doctors were trained. And then in 1960s, 1960 to 1967, the Papua Medical College was formed. And that's when Papua New Guinean doctors came out. And one of the features about that was that when our doctors from Papua New Guinea and Fiji went overseas, their degree, they did not have a degree, they had a diploma in medicine. Unfortunately, the diploma of medicine was not recognized in Australia and elsewhere. Therefore, a push was made by somebody that Papua New Guinea should have its own university. So in 1965, a declaration was made that there shall be a university of Papua New Guinea. In 1966, it was the Ravi Namaliu's group, and 1967 was my group. And at that point in time, they didn't realize that we only went as far as Form 4 of Grade 10. So they said, hang on a minute, these guys are not ready for university courses. So they introduced a 2-year course, or 1-year course, called a preliminary year. Wow. Never had a preliminary year before, you know, even now. This is to prepare these cowboys to go into a university degree program. So that's how the NPS program started in 1967. And I was that first group. There was only about 10 of us, something like that. And when we graduated, there was only 5 of us. There was an Englishman who was who I don't know, he was a missionary. He was a missionary, an Anglican missionary based in Toca, but he came to the court. And there were 2 Australians, Peter Rook and Jim Douglas. And there was a big Tongan guy and a little guy from Pari. So just a 5 of them. And we've come a long, long way. Just before I came, I checked in the admissions number for secondary medical students this year, they said it's about 95. So from 507 to 95, the numbers have grown up. So that's really good. Unfortunately, the population of Papua New Guinea is much higher than that. So the men are winning. The men of Papua New Guinea are winning. So they produce a lot of curates. That's challenging. Sorry to give you all those jokes, but it's good to wake you all up in the morning. Lots of coffee as well. What do they call that? Okay, so the program will demonstrate that Papua New Guinea IMR has been going for a long time. Like I said, 1968 was the first, the very first meeting, 1968 was held at the Faculty of Medicine, 1968. And I walked in there, pushed by Ian, Professor Maddox, to come and listen to this symposium. And I said, what's it about? He said, just come. So I went in, and it was called Kuru. The title was Kuru. And in Motu, Kuru is what comes out of your nose. So I said, excuse me, you have a meeting on Kuru. So I went and settled there, and I was so amazed that it's a completely different subject. And Kuru made Papua New Guinea the International World of Science. And the first meeting was 1968 over at the Papua Medical College. So that's beautiful. That's how it came out. And then later on, the Pig Bill came out. And that was also another interesting one. So Papua New Guinea has been placed in the International World of Science and Research through Kuru and Pig Bill. So keep going, PNGIMR. PNGIMR was initiated in 1968, and we have come a long, long way. And I understand that lots of things are happening in Madang, so there'll be a continuation of our PNGIMR involves further and further on. What about the change in environment? There's a lot of change in environment. I was a fisherman. And every time we went fishing, all the fish from the ocean came down. They all came to the mangroves. And they came and played in the mangrove. And my father and my uncle and I would put a net. And then all those fish that have done all the mucking around in the mangroves, they would come back and we'll catch them so easily. What's happening now? The mangroves are going. As the mangroves go away, then the fish population is going down around here, which means that the Motuans and their exposure to fish is now going down. And fish is very, very important, definitely. In the context of cardiovascular disease, fish are very protective in the protection of lifestyle diseases like coronary disease and stroke and all of those. So that's one of the interesting changes in the world with climate change and whatever happens. Today, the presentations will be all about all of those things. And I'm so happy, I'm so proud that PNGIMR has done all of this. And I look forward to hearing about all these changes. Unfortunately, I will find the students to teach. So I'll be leaving a little bit soon after this a little bit initiation ceremony, and then I will go on. I am very, very thankful for this to go on. And all the changes in the world that are happening, affecting Papua New Guinea, affecting Port Moresby, affecting everybody. And I look forward to hearing your end product at the end. Thank you very much. Have a nice day.
Thank you, Sir Isi Kevau. Thank you, Sir Isi Kevau, for your address. And I would like to also say that Professor Sir Isi Kevau is the PNGIMR Council Chairman. Before we start with our keynote speakers, I would like to acknowledge once again all the attendees that have joined us today. We are happy to have attendees from universities and organizations and institutions across Papua New Guinea, particularly those from Lamana, Kokopo, East New Britain, Madang, and Isipik. We also appreciate our collaborators tuning in from institutions and universities in Australia. Also shout out to those in Townsville and Madang Provincial Hospital. We also have people tuning in from Japan, the University of Tokyo. And those I have not mentioned, we are so grateful to have you join us today. I am now delighted to introduce Dr. Luca de Toca, Australian Ambassador for Global Health. He leads the Global Health Division and the Indo Center for Health and Security at the Department of Foreign Affairs and Trade. Ambassador de Toca represents Australia on the board of Gavi, the Vaccine Alliance. He has also held academic positions in various universities in Australia. Dr. Le Toca from University of New South Wales.
Distinguished guests, colleagues, friends, I'm Dr. Lucas Toca, Australia's Ambassador for Global Health and a long-time admirer of the Papua New Guinea Institute of Medical Research, or PNGIMR. I regret I wasn't able to deliver these remarks live for two important reasons. The first is that we wanted to minimise the risk of bandwidth issues. But secondly, sometime after accepting PNGIMR's kind invitation, but just before this symposium, I agreed to take up a new role in the Australian Health Minister's office. It is a measure of my respect for PNGIMR and its importance in addressing health challenges we all care deeply about that I wanted to follow up through with my commitment to deliver these remarks. And as I finish up in this role, also some reflections. First, I'm recording these remarks from Ngunnawal country in Australia, or Ngunnawal Daura, and I acknowledge the traditional owners of country and in all of the lands on which we are connecting today. I pay my respects to the people, to the cultures, and especially to the elders, both past and present. It wasn't so long ago that the roles were reversed and I was playing host to speakers from PNGIMR. I was privileged last year to visit PNG. A highlight was hosting Professor William Pomat, Professor Moses Laman and Dr Pamela Tolliman to deliver the Ruth Bishop Address at the Australian High Commission in Port Moresby. That was the first time this event had been hosted outside of Australia. This prestigious address celebrates the contribution of the late Ruth Bishop, AO, who led the team that discovered rotavirus, paving the way for the development of vaccines that avert hundreds of thousands of deaths each year. Every year, we honour her work by showcasing researchers making a genuine mark on health security issues in our region. So it was fitting to celebrate PNGIMR, which has done so much for health security for the whole Pacific. I was grateful to have the opportunity to hear more from PNGIMR about its work, because as we all know, the health challenges facing PNG and our shared region are real and substantial. With declining child vaccination rates across Southeast Asia and the Pacific after COVID-19 and the subsequent backsliding, outbreaks of key vaccine-preventable diseases such as measles are a growing risk, including in PNG. We are seeing a very concerning rise in HIV cases in PNG, as well as Fiji and the Philippines. Alongside these communicable diseases sits a growing burden of non-communicable diseases. Diseases like cardiovascular, cancers, diabetes and chronic respiratory diseases continue to be a major public health problem in the Pacific, accounting for a significant number of deaths and premature mortality. Australia is committed to supporting our region to tackle these health challenges, but a one-size-fits-all approach clearly won't achieve that. There's a lot that we share, but different countries, in fact in some cases different provinces, will have very different experiences and needs. So in this complex context, it is essential that we can be confident our interventions are right and they fit locally. That's a critical reason why we need local research to guide and inform public health decisions. Locally led research puts local communities and experiences at the heart of the response. And importantly, local research puts PNG first. We are here backing PNG's priorities and aspirations. But it is Papua New Guineans who have the most at stake. And this is where the PNGIMR comes in. A capable, highly skilled, National Health Institute focused on the needs of the community it serves, one that has shown that local research into local issues can lead to effective local solutions. This principle is at the heart of both PNGIMR's approach and Australia's commitment in our region and beyond. As PNG celebrates its 50th anniversary of independence this year, remarkably, PNGIMR celebrates its 57th. Under the guidance of the late Professor Alpers, PNGIMR transformed from humble beginnings to becoming a deeply embedded and important presence in PNG's health landscape. I was pleased we were able to recognise Professor Alpers' contribution with the Alpers Award, conferred this year on Susina Yatapia for her important work on pregnancy and malaria. PNGIMR has also conducted research into challenges like HIV, tuberculosis and malaria, child stunting and malnutrition, which has informed more sustainable and realistic interventions for these issues. PNGIMR's current work with UNICEF and the Swiss Tropical and Public Health Institutes to research behavioural and social drivers of immunisation and child health in PNG will be key to improving immunisation coverage in Papua New Guinea. PNGIMR's impact does not stay just in PNG. Its longevity and proud record also means that PNGIMR has become an esteemed voice on public health research for our broader region, using its lessons and experiences to guide other countries on their own public health journey. Australia is so proud to have supported PNGIMR for many decades. From infrastructure to institutional capacity building and research activities, we are pleased to back PNGIMR to deliver on its ambitions and fulfill its potential. We also have a strong relationship with the Buttressing Coalition, a key partner for the Institute, including working together on health security initiatives in PNG. The Buttressing Coalition precedes my time in this role by 25 years. It started in 1999 as a group of like-minded research institutions that all work with PNGIMR and under Professor Alpers' guidance came together to support PNGIMR's development as an institution. In 2018, the Australian government saw an opportunity to help the Buttressing Coalition to strengthen its support for the Institute through a co-funding arrangement and a revamp of the membership charter. This change introduced institutional membership fees for the first time, and I hope the Buttressing Coalition is well placed to continue to support this work in the future. Australia's support to PNGIMR is part of our multifaceted and wide-ranging partnership on health. It's guided by PNG's own needs and priorities, and it encompasses support for day-to-day service delivery, but also assistance to construct facilities, boost practitioner skills, and build the foundations necessary to deliver better health for all Papua New Guineans. As PNG celebrates its anniversary of independence, it is an opportunity to reflect on our shared history, celebrate our contemporary friendship, and where we want to go in the future. Australia's You Missed Up One Time campaign for this special milestone recognises our enduring partnership, shared values and deep people-to-people ties. PNGIMR embodies many of the best aspects of our nation's relationship: shared respect, shared priorities, grounded in genuine connections and shared history. Driven by its leadership and commitment to be a centre of excellence in public health and medical research in Papua New Guinea and globally, PNGIMR is ensuring research goes beyond theory into practice to save lives and build healthier communities. As I wrap up, both this speech and in this role, it is a chance to reflect on those partnerships, friendships and experiences that have most profoundly shaped my understanding and perspectives on health issues in the Pacific. The PNG Institute of Medical Research is one of these. As a public health researcher and practitioner, as well as a diplomat, I have become acutely and personally aware of the importance of PNGIMR, and I am proud that Australia's commitment to PNGIMR is not just about bricks and mortar, but it is seeking to empower the Institute in delivering its vital work and playing a role in transforming PNG's future. I will always look back fondly on my too brief time in PNG, and I'm grateful to have the opportunity to speak today. I hope the rest of the symposium is a success. I know it will. Thank you, Tru, and see you soon.
Thank you very much, Dr. Lucas de Toca, Ambassador for Global Health for DFAT. I want to say thank you very much to you for doing the keynote this morning and for enlightening us on the work that you're doing. We'd also like to thank you very much for what you have done for PNGIMR particularly, but also the health in Papua New Guinea for all the work that has been coming through the Australian HICOM plus your support throughout as well. We wish you all the best in the next job that you will be heading for, and hope that we continue to work well with you and with the new person that will be taking over your role at the Center for Health Security. So thank you very much, Lucas. We look forward to meeting you again someday. But again, wish you all the best for the future. At this stage, I also want to say thank you to all our partners that continue to support the Institute in the US, in particular Case Western Reserve University, in Australia, the Kirby Institute, Murdoch Children's Research Institute, the Kids Institute in Perth, Wollongong University, and all our partners in Melbourne, Perth, and elsewhere around the country. Also, a shout out to all the Papua New Guinean institutions or representatives of different institutions that are currently online, looking at us, watching this program as well, and trying to see if we can build our own partnership to ensure that we, as the world changes, that we have partnerships in place to be able to do a better job going forward to better the health of Papua New Guineans. So thank you very much for everyone for watching. We now go to the next session. I'll hand it back to our host.
Thank you, Professor Pomat. It is now my privilege to introduce Dr. Donald Wilson, a fellow Pacific Islander from Fiji. Dr. Wilson is the Associate Dean of Research at the College of Medicine, Nursing and Health Sciences at Fiji National University. He's a physician and a PhD in occupational and environmental epidemiology. His current research focuses on water-sensitive diseases, emerging communicable diseases, sexual and reproductive health, and the disease burden of non-communicable disease. Dr. Donald Wilson from Fiji National University.
Good morning, Almeri Naman, Yandavinaka from the Fiji Institute of Pacific Health Research. I am deeply honored to be invited to share a few thoughts in a keynote address at the 2025 PNGIMR Virtual Symposium. Many thanks to my esteemed colleague, Professor William Pomat, and his leadership team, as well as the organizers of this annual event. While I hope to address the theme Research Evidence for a Changing World, I also considered this an opportunity to reflect on the Healthy Islands vision and lead on to a shared vision to work together with colleagues at PNGIMR, and therefore have added realigning the Healthy Islands vision to guide research towards healthier populations in Melanesia as the title of my talk. As an outline of my presentation, I'm going to talk about some of the health challenges in the region as brought to us by the Heads of Health meeting. I'll reflect on the Healthy Islands vision, talk about some planetary health initiatives, and maybe wrap up with some opportunities for collaboration. In April of 2025, the Pacific Heads of Health from across our region met in Nadi, Fiji, and discussed the usual agenda for the Heads of Health meeting that happens every year, with highlights of burdens that are new or are emerging or that continue to burden the health of our people and our populations across the Pacific. Of the many discussions that transpired over the 3 days, I'll share with us three of the burdens of health that are happening across our region at this very moment. The first is increasing mental health problems. The Pacific is experiencing a rising prevalence of mental disorders, as that graph shows. Currently, more than 1.5 million people in 2021 were affected by mental disorders, while at least 200,000 people experienced substance use disorders. And the Pacific Island countries have some of the highest suicide rates in the Western Pacific region, and this is particularly because of a surge in illicit drug use that has become a critical public and social concern across the Pacific, and that has significantly contributed to the surge in the HIV problem. Mental health with substance use is a recognized critical public health issue in the Pacific, and part of the problem is because our mental health systems are also underdeveloped, and that is compounded by a rise in increasing illicit drug use across the Pacific Island countries. Major barriers to this as a problem is because we continue to have stigma and discrimination against mental health. Our policies are inadequate and old. Our information systems are weak. Our workforce is limited in terms of its capacity, particularly for substance use disorders. And mental health has insufficient integration into general health systems, plus a lack of peer support and surveillance at the community level. The second problem that we're dealing with in the Pacific is antimicrobial resistance. We all know that AMR, which is basically when pathogens like bacteria, viruses, and fungi that cause infection become resistant to antimicrobial treatment. And this is caused largely by misuse and overuse of antimicrobials. And the development of new antimicrobials is not on par with the rising level of AMR. AMR, we know, is a global problem, but also in the Pacific Island countries, it's becoming a growing public health threat. and it's spreading across healthcare settings and into communities. Genome sequencing has revealed the presence of the New Delhi strains of carbapenem-resistant Antibacterialis, which is a superbug, the Southeast Asian and Australasian strains, and locally induced strains of MROs in Pacific Island countries. The inter-country spread is compounded by travel and patient referrals across our borders, and some Pacific Island countries face significant challenges as MRO infection compromises patient care and clinical outcomes. Across the Pacific, the Secretariat, which is the 4AMR, which is the Pacific Community, shares a dashboard for countries with a list of targets and indicators for countries to work against and document AMR activities and progress in these initiatives on this matrix. The third and the last one that I'd like to share that came out of the Heads of Health meeting of this year is a growing HIV problem. You've probably heard of the outbreak that's happened in Fiji and this was announced in January of this year. But in 2024, from January to September of 2024, 1,093 new cases were diagnosed, and that was a 3 times increase from 2023 and a 9-fold increase over 5 years. 50% of those cases are not on treatment, and 50% of new infections are linked to injecting drug use. The latest data is showing that from September of 2024 to date, we've had a total of 1,500, more than 1,500 cases of newly diagnosed HIV cases. And the case for Fiji is highlighting also an increased risk for a regional spread, and this is because of the known vulnerabilities that exist in our Pacific Island countries. And this is documented by different pieces of information that are available by studies that have been conducted. One is, I'm sure that some of you might have heard of the MICS, or the Multiple Indicator Cluster Study, that is usually run by UNICEF and UNDP. And this is basically showing data for the studies that were conducted in 2018 to 2019 for the countries of Kiribati, Samoa, and Tonga, and the latest was in 2023 for Vanuatu. And it is showing the underlying vulnerabilities in these Pacific Islands based on the data that's come out of these mixed studies. For instance, for Vanuatu in 2023, it showed that the first engagement in sex for females is 2.8% and 5.5% of males less than 15. I'll just rephrase that 2.8% of males under 15, females under 15, and 5.5% of males responded that they engaged in first sex before they were 15 years of age. In addition, there is documentation across the countries of low condom use, and that is only 9.9% in females and 31.9% in males in Vanuatu, and a lack also of HIV knowledge, and this is showing across the 4 countries that have had their mixed studies conducted. From that bird's eye view of the current health burdens of our region, allow me to help us reflect on a critical health commitment made by our region, the Healthy Islands Vision. In 1995, Pacific Island health ministers gathered on Yanuda Island, Fiji, to declare a visionary ideal, a holistic framework linking human well-being with environmental stewardship. The 4-part vision for Healthy Islands of the 1995 meeting included one that aspired for ecological balance. They imagined island communities where children thrive, people live and age with dignity, and ecological balance is a source of pride. At the convening of the same Pacific Heads of Health 20 years later, in 2015, the vision became a 5-part declaration, with the inclusion of yet another ecological aspiration, that the oceans which sustains us is protected. This Healthy Islands vision anticipated by decades the core principles of today's planetary health movement. Indeed, as one Pacific Health official later observed, the Healthy Islands vision was ahead of its time. Its time is now. 30 years on, amid escalating climate and health crisis, that vision now demands urgent realization. A critical shortfall, however, lies in how progress is measured. The current Healthy Islands monitoring framework underrepresents ecological determinants of health. Of its 48 indicators, only 5 reside in the environment or ecology pillar. Even these few environmental indicators are patchily reported. Fewer than half of Pacific countries have recent data, and none have data for climate change and natural disaster resilience. Crucially, the framework omits direct measures of natural system health. There are no metrics yet for forest integrity, biodiversity status, watershed, or coral reef condition, despite their obvious impact on food security, disease ecology, and community well-being. This gap leaves decision makers partially blind to ecological trends that underpin health outcomes. These converging crises echo the foresight of the 1995 declaration that human health ultimately depends on thriving ecosystems. We know that humanity globally has crossed at least 6 of 9 planetary boundaries, pushing the Earth outside the safe operating space for sustainable development. Pacific Island countries and territories are the front lines of intertwined environmental and health challenges, exacerbated through reaching these planetary tipping points. The region is among the most vulnerable globally to the health impacts of climate change, facing trauma from extreme weather, threats to water and food security, surges in infectious disease, and rising NCD burdens. Intensifying cyclones, sea level rise, deforestation, and resource losses have all eroded livelihoods and strained our health systems. To truly fulfill the original purpose of and promise of the Healthy Islands, Pacific health leaders and development partners must upgrade data collection and indicators to integrate these ecological determinants fully. Monitoring platforms must incorporate indicators of watershed quality, reef vitality, forest restoration, and biodiversity alongside traditional health metrics, and these indicators must be informed by indigenous and local knowledge systems to ensure cultural relevance, ecological validity, and community ownership. Strengthening environmental surveillance and linking it with health information systems will enable proactive preventive policies. Investing in such data, integrated data systems, and cross-sector analytical capacities, Pacific Island countries can better manage environmental changes' cascading effects on human health. This shift also aligns with broader regional visions, notably the Pacific Leaders 2050 strategy for the Blue Pacific continent, an overarching blueprint for regional resilience and health equity. Embracing planetary health will unite objectives under one umbrella, accelerating progress on climate adaptation, food security, and pandemic preparedness. By marrying ancient wisdom with cutting-edge science and updating success metrics to include the pulse of nature, the Healthy Islands vision can be reinvigorated for the 21st century. The Healthy Islands vision was ahead of its time. Its time is now. Realigning Pacific health development with ecological stewardship requires political will, innovative partnerships, financing mechanisms, and inclusive leadership. Institutional frameworks should institutionalize whole of government and whole of society collaboration towards shared goals. Regional technical agencies such as the Pacific Community, SPC, and the Secretariat of the Pacific Regional Environment Program, SPREP, have a critical role to play in supporting this collaboration through evidence generation, policy guidance, and capacity building. It's encouraging to see that a new generation of Pacific leaders and scholars is emerging with a passion for climate action and ancestral wisdom, driving sustainable lifestyles and holding governments accountable. At the Oceania Planetary Health Forum that was held in February this year, we launched the Fiji National University's Pacific Planetary Health Research Center. By integrating expertise in public health, environmental and climate sciences, water sciences, microbiology, genomics, ecology, and biodiversity, we want to ensure a comprehensive understanding of the natural and human systems at play. Our focus on policy and systems change, combined with socioeconomics, community development, and urban planning, enables us to design and implement effective, sustainable interventions. More importantly, the centering of indigenous knowledge and the lived experiences enriches our research, grounding it in the realities of local communities and enhancing its relevance and impact. By bridging these disciplines, our consortium is at the forefront of mission-based transdisciplinary research capable of delivering holistic solutions that address the interwoven challenges of health, environment, and social well-being in the Pacific and beyond. Following the launch of the new Pacific Planetary Health Research Center at FNU, we also received communication from the Global Planetary Health Alliance, inviting the Planetary Health Research Center at FNU to serve as the host institution for the Planetary Health Oceania Regional Hub. This hub would now coordinate regional efforts to convene stakeholders across academia, government, and civil society throughout the region, foster interdisciplinary collaboration and capacity building, and also represent Oceania's voice within the Planetary Health Alliance's network and meetings. Within the Pacific Planetary Health Research Center currently sit two programs that are planetary health approach in nature. One you've probably heard of is the RISE program, Revitalizing Informal Settlements and Their Environments, and the second is the WISH Pacific program, Watershed Interventions for Systems Health. I will briefly touch on both these projects before I wrap up my presentation today. The RISE project, Revitalizing Informal Settlements and Their Environments, is based in Fiji and in Indonesia, Makassar, Indonesia. It is a randomized controlled trial that is community-based. There are 12 informal settlements in both these countries, 6 study sites and 6 control sites. The background is addressing the plagues of leptospirosis, typhoid, and dengue, and particularly diarrheal disease, in knowing that informal settlements, because of the informal nature of their setups, drinking water is almost always contaminated with fecal material because of the regular mixing of drinking water and sewage water. Flooding happens quite regularly, waters rise, they settle again, fecal material is almost always drying on the soil surface, and so children are exposed, and due to these exposures, drinking water with fecal material always in the system, and children, especially under 5, are always the prevalence of diarrheal disease in the under 5 age group is always very prevalent in informal settlements. And so as part of the program, this slide shows the different kinds of samples that are collected according to the objectives of the study. For example, objective 2, aim mosquitoes, eye buttons, and acoustics downloads, and also collection of soil and environmental water, reticulated water, buttsocks, and scats. Objective 3 requires the collection of bloods and feces, and objective 4, the administration of a well-being survey questionnaire. These samples are collected every quarter, while bloods are collected once a year. The assessment of these samples are done before the intervention, during the intervention, and post-intervention to be able to measure change and the impact on human health in these informal settlements. The second study that I'd mentioned is the Watershed Interventions for Systems Health. Similar to RISE, it also looks at addressing the plagues of leptospirosis, typhoid, and dengue. The only difference is that the WISH program is situated in 29 rural indigenous communities, and also this included 2 non-indigenous communities, which allowed us the opportunity to also share the same learnings across different kinds of rural communities in Fiji. As you will see from this study, the WISH approach combines multiple disciplines, for example, health, environment, engineering, to address complex water-related health issues in a transdisciplinary approach. And it considers the interconnectedness of human health, ecosystem health, and animal health in a watershed place-based setting. Secondly, WISH involves in community engagement, involves local communities in all stages of the project, from planning to implementation and evaluation, and it also builds capacity and empowers communities to take ownership of their health and their environment. Thirdly, the WISH project also in evidence-based interventions utilizes scientific evidence to inform decision-making and select appropriate interventions. It also monitors and evaluates the impact of these interventions to ensure effectiveness and sustainability. And the project also recognizes the complex interactions within ecosystems and human societies via systems thinking, and also tries to address the root causes of these water-related health problems rather than just the symptoms. And finally, the WISH approach tries to develop scalable and sustainable solutions that can be replicated in other contexts. It also builds institutional capacity to ensure long-term impact and ownership of the project. To wrap up, and as we consider opportunities for sharing engagements that are truly aligned to the spirit of the Healthy Islands vision, here are a few points for consideration and further discussion. The WISH Pacific and the Wildlife Conservation Society project that is in Manus. When we were in Goroka last month, we talked about translating the Fiji learnings from WISH Fiji to the project that has started in Manus. And also we're happy to engage with PNGIMR and colleagues in PNG on planetary health approaches. If you are interested in what I'd shared earlier on about the RISE and the WISH projects. And we've, in our visit also last month to Goroka, we discussed with Professor William Pomat and his team about possible collaborations in projects maybe in typhoid, and also using HIV and STI data for both Fiji and PNG for comparatives, as well as opportunities for genomics. I didn't share today, but one of our research centers, our Communicable Disease Research Center, also just completed Fiji's national sero survey for COVID-19, which took over 2 years to complete in Fiji. We now have 4,000 samples of serum that have been aliquoted, and that we've also been able to try and run sero survey for dengue, and there is opportunity also for other sero surveys, and I think that is another opportunity that we can take advantage of. As we work on linking up research across Melanesia, I was pleasantly surprised to learn that the Melanesian Spearhead Group was established in Goroka 39 years ago. So that's to be 40 years ago next year. And I think it is timely that we probably start a discussion with Melanesia, starting with Papua New Guinea. So the Fiji Institute of Pacific Health Research is excited about setting up a long-term relationship with our friends from PNGIMR. With that said, thank you so much once again for inviting me to this virtual symposium, and from the Fiji Institute of Pacific Health Research and the team at the College of Medicine, Nursing and Health Sciences at the Fiji National University. Thank you so much, and I wish you all the best in your deliberations for your symposium today. Inaka, thank you.
Thank you, Dr. Don Wilson, for your extensive work on HIV that provides very important information in the re-emerging of HIV in the Pacific. And we also look forward to collaborating with you and your team from Fiji. Before I pass it on to Professor Pomat to introduce our next session, I would like to do a couple of shout-outs, especially to our important research partners, the PHAs, from Eastern Highlands, Simbu, Madang, and Kainantu. Also shout out to POM, the NDOH, DFAT, Planet Team, POM Gen, and UPNG, and CPHL in POM. In Madang, shout out to Madang BSP, Divine Word, BMBM, Madang City Pharmacy, and those in Yagam Clinic. Here in Goroka, shout out to the Malaysian Institute, Asaro NGO, and Lutheran Church, UOG, and NBC. And now I would pass it on to Professor Pomat to introduce our next session. Thank you.
Thank you. So this next session is quite an important session and all about the theme of the current virtual symposium. And so we will hear some of the research work that is currently being conducted through the Institute. And this is only a small part of the whole research work on One Health. And so I hope that you will listen to this, learn from it, but also that you find ways for us to work together to be able to produce better research right across Papua New Guinea, across the different environments that we all have, because us in the highlands might have a different system that we will be faced with, whereas those on the coast might have something else. And so across all of our systems, we need to come and work together and ensure that we find the evidence to be able to then work into the future. So let me introduce Dr. John Bosco Keven, who is an entomologist by training. He will be the host for the next few minutes or in the next session to be able to go through some of the work that him and his teams are conducting, plus some of the other work that are parts of the Institute are working on. So thank you very much. I hope you enjoy the next session. John? Yep, okay.
And I would like to say a little bit about Dr. John Bosco Keven. Dr. Keven is a postdoctoral research fellow with the Vector-Borne Disease Unit, PNGIMR in Madang. He holds a doctorate in microbiology, molecular and genetics, and a master's in medical entomology from both from Michigan State University. He is currently the first PNG national to lead the PNG malaria indicator survey. Dr. Keven is a leading PNG national medical entomologist and vector biologist with an extensive research portfolio, outstanding publication record in vector, ecology, and transmission of malaria, and arbovirus in PNG, Africa, and North America. His research program recently includes studies on the impact of climate and environmental change on mosquito, vectors, and vector-borne disease in PNG. Dr. John Bosco Keven.
Introducing to you, Dr. Bosco.
Oh. It's okay. Hey, can everybody hear me? Thank you, Prof. Pomat and Dr. Gwendalyn Vengiau for the fine introduction. It is my pleasure to host the important session on One Health and climate change. We will begin with two presentations on the effect of climate change on vector-borne diseases, with a special focus on malaria, delivered by Dr. Stephan Karl and myself, followed by 6 presentations on system science and One Health. We will have time for questions from audience, but at the very end of the session. So our first speaker is Dr. Stephan Karl, who is an associate professor at Australian Institute of Tropical Medicine at James Cook University. He is also the head of entomology lab for PNGIMR based in Madang. Dr. Karl is a highly experienced researcher in the field of vector-borne disease and has worked with PNGIMR for more than 15 years. So ladies and gentlemen, please welcome Dr. Karl's pre-recorded presentation.
Good morning, everyone. My name is Stephan Karl, and I'm going to talk about climate change and health in Papua New Guinea. I'm not really an expert on climate change and health in Papua New Guinea, so I'm referring you to the National Adaptation Plan, which is a great summary of everything to expect around climate change in PNG, also with respect to health. But as far as I can see, all major climate change impacts will somehow affect health. You can see them listed here on the side. Coastal flooding and inland flooding will obviously affect health in some way. Food insecurities will affect health. There's going to be impacts on cities, climate change induced migration, damage to the natural environment, such as the tropical rainforests and the coral reefs, an increase in malaria and other vector-borne diseases, which I will mostly focus on in this presentation, and then also impacts on water and sanitation, all of which are going to impact health in one way or another. So I just picked this example of sea level rise here to illustrate, the impacts of climate change going forward. I think it's important to understand that climate change is real and that future generations will be impacted by this, and that this significant impact is not too far away anymore. By 2100, the latest estimates of sea level rise contributions from Greenland and Antarctica sum up to 1 meter above sea level, but totals may be as high as 2 meters above sea level by 2100. So in order to illustrate the significant impact of sea level rise on PNG, I'm just showing some examples here what 1 meter sea level rise would mean for some PNG population centers. So the areas in red in these maps here are areas that would become flooded if we were to experience a 1 meter sea level rise. You can see Kerema, Kavieng, Wewak, Madang and Buka are not going to be the same as we know them today. So the National Adaptation Plan sees NDOH, the provincial health authorities and PNGIMR in the responsibility for evidence-based planning and decision-making to develop climate change adaptation strategies in the health sector in PNG. That is supposed to be an ongoing process at the moment, targeted for 2023 to 2026. It includes the development of standardized assessment tools to assess the health impacts of climate change, to conduct vulnerability and adaptation assessments, to develop strategies and systems to improve the monitoring of health impacts of climate change, to establish climate health information systems, and to also assess the cost of climate change impacts on health in PNG. So in line with this, and in the second part of my presentation, I'm going to focus on such an assessment, which is a small study that we've recently conducted on climate change and temperature suitability for malaria transmission in PNG. So as most of you will know, PNG records around 1.2 million malaria cases per year. That's 85% roughly of all the cases in the Western Pacific region. However, about 40% of PNG's population live in areas above 1600 meters where the temperature doesn't really support stable malaria transmission. It's too cold. And so this analysis explored if rising temperatures as a consequence of climate change will shift transmission to higher altitudes in the future up to 2040. And the aim of this study was to build an understanding about the impact of climate change on malaria transmission in PNG to inform future program preparedness. So what determines temperature suitability for malaria transmission? Many mosquito and parasite parameters governing malaria transmission are functions of temperature. Things like the biting rate, vector competence, daily survival probability of mosquitoes, mosquito development rate, and parasite development rate are all functions of temperature. All of these parameters can be combined into a quantity called the basic reproduction number, or R0, which then also becomes a function of temperature. R0 is a measure for the temperature suitability of malaria transmission in an area. It is then defined by this rather horrible looking equation. I want you not to worry too much about this equation, just the takeaway message that malaria transmission is temperature dependent, and this temperature dependence can be expressed by this quantity called the basic reproduction number, or R0. Based on R0 estimates, malaria transmission is possible between around 17.5 and 33.5 degrees Celsius with an optimum of around 25 degrees Celsius. Of course, transmission also depends on a whole range of other factors, and temperature within this range is necessary but not sufficient to sustain malaria transmission. Now, the question of this study was, how does this basic reproduction number, or R0, relate to altitude in PNG in the present and in the future, considering climate change? So in order to do this, we acquired temperature data for the present and for the future from a website called worldclimate.org for the future prediction from 2021 to 2040. These temperature estimates are based on so-called socio-economic pathway models and general circulation models. Other data sources included PNG's administrative boundary, a digital elevation map, and population density distribution models. All these data layers were overlaid with a 2.5 by 2.5 kilometer grid layer covering PNG. And then the average monthly temperatures were calculated for each of these 2.5 by 2.5 kilometer grid squares for 2 decades, 2010 to 2019 representing the present day, and 2021 to 2040 based on the future prediction. And then R0, the basic reproduction number, indicating the degree of temperature suitability, was calculated based on the average temperature for each grid square using a previously published model. A few words on these climate circulation models and shared socioeconomic pathway models that are used to predict future temperatures. Obviously, they are based on a broad range of assumptions that are usually summarized in this kind of way. So depending on how optimistic or pessimistic you are about the future, you can choose one of these models. And in order to establish a conservative estimate, I selected what is called the SSP245 model, which is also called the middle of the road model, which is basically extrapolating based on the past and current global development into the future. So nothing out of the ordinary, not a particularly optimistic scenario where everybody is working together hand in hand to fight climate change, because that is not what we're seeing, but also not a very pessimistic model where everybody is going to war over resources, etc., etc. A middle of the road, medium pathway model. So based on this model, what kind of temperature increase can we expect in PNG between 2010 to 2019 and 2021 to 2040, so between the present and the future? So the answer to this is that we can expect an average of 1.33 degrees Celsius temperature increase across the country. And that will then obviously also lead to an increase in the transmission suitability for malaria, or this R0 quantity that I was explaining in previous slides. Because as it gets warmer and the temperature increases, the transmission suitability in certain areas of PNG that are currently too cold, which are mostly located in the highlands, increases, and these areas become actually suitable for malaria transmission. And you can see that here in the graph as well, that shows delta R0, so the change in the transmission suitability over altitude, and there's a certain altitude range between about 1,000 and 1,500 meters where the transmission suitability for malaria increases by quite a considerable margin of about 0.25 to 0.3. Don't forget that this R0 is a relative value that scales between 0 and 1. So an increase of 0.25 to 0.3 is quite a significant increase. And you can see in the map here where these positive changes to R0 are mostly occurring, and that is obviously the highlands and highlands fringe areas in PNG. So one cool thing that we can do with a spatially explicit model such as this one is we can look at different locations and how malaria transmission suitability is going to be impacted by climate change in different places across PNG. I have chosen Goroka here as a case study. In Eastern Highlands province, you can see on the population density map this red blob, this encircled area is where Goroka is, where the population density is high. The map adjacent to this shows again delta R0 in a spatially explicit way. And you can see that many of these highlands valleys in Eastern Highlands province will basically experience considerably increases in malaria transmission suitability. This will not be homogeneous across the year, but it will be seasonal. And so you can see here the predicted seasonality of transmission suitability for the Goroka area as well in this graph. And so I guess the take-home message from this is that transmission suitability of malaria in Goroka will increase significantly over the next decade or two, and we would be expecting an increase in indigenous malaria cases around Goroka between now and 2040. So in conclusion, we can say that within the present and the next decade until 2040, temperature is predicted to rise by about 1.3 degrees Celsius in a conventional climate change scenario. And this will lead to a shift in the altitude range, sustaining malaria transmission by about 263 meters, and will affect larger populations in the PNG highlands. One last question is, what does this mean for the total population at risk of malaria transmission in PNG? So to answer this question about future populations at risk of malaria transmission, I consider two simple models. The first model only assumed population growth and no climate change or temperature increase, and the second model assumed that there was going to be population growth and then also a temperature increase due to climate change, which would then lead to an expansion of these malaria-prone areas, as we have discussed in the previous slides. So, and now we're going to compare and contrast these two models and how they predict the population at risk between now, or between 2019 and 2040. So in 2019, there were about 11.2 million people in PNG based on UN estimates, and about 6.5 million lived in areas that were prone to malaria transmission. So that would be excluding these highlands areas that are above the transmission level. Now, by 2040, about 18.6 million people will be living in PNG based on population growth. When we assume that there's no temperature increase, no climate change, about 10.9 million people will be living in malaria endemic areas in PNG in 2040. When we consider population growth and temperature increase, so the expansion of these malaria-prone areas into these highlands regions, this number will increase to about 13.7 million people. So 2.8 million people will be living in malaria endemic areas in PNG by 2040 due to climate change. Overall, this means that the total population living in risk areas of malaria transmission is expected to double between now and 2040. And 50% of this increase will be due to rising temperatures due to climate change. As such, maintaining the current levels of malaria control in PNG, we're not talking about malaria elimination, we are not talking about reducing the number of cases or anything, we're talking about maintaining the current levels of malaria control in PNG will require substantially more resources. So I hope this presentation hasn't made you feel too bad about the future. I apologize if it did, and I hope you enjoy the rest of this climate change session. Thank you.
Thank you very much, Dr. Karl, for a fine presentation. This is a kind reminder to the audience for if you want to post questions, please go ahead and post your comments in the chat. So you can click on the chat icon at the bottom right of your screen. So Dr. Karl's work on the epidemiological modeling of the expansion of malaria into the highlands is valuable in predicting the effect of climate change on vector-borne diseases, but empirical data are necessary to show whether the prediction is real or not. So in the next presentation, I'm going to discuss some preliminary empirical evidence of the effect of increased surface temperature on the proliferation of Anopheles mosquito vectors and local malaria transmission in the PNG highlands. So in the past, because of low temperature, highland areas greater than 1,500 meters in altitude were generally inhospitable to the establishment of stable populations of Anopheles vectors of malaria. Consequently, malaria was absent or considered non-endemic, with occasional outbreaks in these areas. However, because of climate change, surface temperature in PNG has increased by approximately 2.5 degrees Celsius since 1970. Therefore, vector ecology and malaria epidemiology in the highlands are expected to change in response to the temperature change. there are several species of Anopheles mosquitoes that transmit malaria in PNG. Of these several species, 5 of them are the key or the main vectors that transmit these parasites in PNG. The objective of this study was to investigate the hypothesis that the increase in surface temperature has caused Anopheles mosquitoes to proliferate and form stable populations in the highland areas above 1,500 meters. Now, this is important because this change causes the epidemiology of malaria in the highlands to change from non-endemic with occasional outbreaks to one that is endemic. This increases the proportion of PNG populations at risk of malaria infections. In order to test this hypothesis, we conducted a mini mosquito surveillance project that was done along the PNG National Highway starting from a site Watarais in Morobe all the way up to Mins in Jiwaka. Now, this is an altitudinal climb as we did the sampling, mosquito collections. The other 3 sites are Henganofi in Eastern Highlands, Asaro also in Eastern Highlands, and Migende in Chimbu. The lowest altitude was 426 in Morobe, and the highest was 1,688 meters. Mosquitoes were collected using light traps and human landing catch method for 3 nights in each of the study sites. And here are the results of our study, our mini study. In the table, you can see the distributions of Anopheles mosquitoes that were collected in the different study sites according to the species, okay? But I want you to focus on the pie chart on your right. You will see that of 196 Anophelines that were collected in the study, 64% of those were from the one site in the lowland area, whereas 36% of those, which is a notable proportion, was collected in 2 of the 4 highland sites, which was Migende and Mins. Migende in Chimbu and Mins in Jiwaka. 8% of those came from Migende and 28% came from Mins. Okay. Now, when we compare the results of what we found with the survey, with the survey that was done very intensively and comprehensively in 1992 to 1996, which was a 6-year-long project, the study yielded only 14 Anopheles in areas greater than 1,500 meters. Okay. Now, if you compare that to our survey, which was neither intensive nor comprehensive, our study produced or yielded 5 times more Anopheles than the previous study. Okay. In our recent malaria indicator survey in May of 2025, our team conducted a survey of malaria in Chimbu and Eastern Highlands province. They tested 1,428 individuals by rapid diagnostic test and found 7 positives. Of those 7 positive, 4, which is 51% of the total positives, had a history of travel to the lowland areas. So we presume that these people were likely to be cases or imported cases, meaning that they went down to the coast, got infected, and came up to the highlands. 3 of those, however, which constitute 49% of the positive cases, had no travel history, which indicates that these are probably local transmission, which means that they got infected from where they were, probably by the Anopheles mosquitoes population that were within the same area in which they live. So in conclusion, the relative ease of collecting Anopheles mosquitoes above 1,500 meters in our survey compared to the past survey indicates the proliferation of malaria vectors in the PNG highlands in present times. The presence of infected people without a history of travel or malaria outbreak indicates local transmission of the parasites by stable populations of Anopheles mosquito vectors in the highlands. And the change in vector ecology and malaria epidemiology that we are seeing here in the highlands is most likely caused by the increase in surface temperature or global warming. Thank you very much. And here's an acknowledgement slides for if you can see, but in the interest of time, I'm just gonna skip through this and move forward. Okay, so now, thank you very much for listening to what I just said. I'm going to now move on to our next speaker, Let us now move on to our speaker for the component on system science and One Health. Our first speaker is David Williams. Dr. Williams leads the Diagnostic and Mammalian Infectious Disease Research Group at the CSIRO, Australia Centre for Disease Preparedness. Okay. His work focuses on the detection, diagnosis, pathogenesis, and epidemiology of emerging transboundary viruses that affect animals, humans, including zoonotic arboviruses. He has extensive experience working on lab and surveillance capacity building projects in the Pacific and Southeast Asia. Since 2018, he has led Australian Centre for International Agricultural Research, funded projects on One Health approach to surveillance for Japanese encephalitis, and collaborating with PNGIMR, NAKIA, JCU, James Cook University, and Bennett Institute. He has also collaborated on the STRIVE project and is a member of the DFAT-funded PNG LabCap project. Ladies and gentlemen, please welcome Dr. Williams' pre-recorded presentation.
Good morning, everyone. It's a pleasure to be presenting to you here today at the PNGIMR Virtual Symposium. Firstly, thanks to Anne Larson for the invitation and opportunity to present on our work on a One Health approach for surveillance of Japanese encephalitis and other zoonotic arboviruses in PNG. So what I'd like to do today with this talk is to introduce the project as well as the One Health concept before handing over to other project members who will tell you about specific aspects of the work. But before I do that, I'd like to give you some brief background on the arboviruses we are interested in for this project. This slide shows a list of arboviruses of medical and veterinary importance in the Asia-Pacific region, including in Australia. The viruses shown in black font are zoonotic viruses, meaning that animals are involved in their ecology, whereas those in blue primarily circulate within human or primate involvement. At the top, we have Japanese encephalitis, Murray Valley encephalitis, and Kunjun, which is a subtype of West Nile virus. All of these are notifiable diseases in Australia, and all can cause encephalitis in humans and some species of animals. The other virus I wanted to highlight is Kookaburra virus, which Joelyn will talk about in her presentation. This is a virus that has been rarely found to cause human febrile disease, but is commonly detected in Australia. So focusing on Japanese encephalitis virus, which is our main disease focus for this project, this virus taxonomically is or belongs to the Orthoflavivirus japonicum species of the family Flaviviridae. It's the most important cause of viral encephalitis in human populations in Asia and can cause around 68,000 cases per year worldwide. But that's often thought to be an underestimate, and it may well cause over 100,000 cases in some years. This can also cause neurological disease in horses and reproductive disease in pigs, as we saw in Australia over the last wet season and in 2022 as well. In Southeast Asia, the highest incidences occur in developing Asian countries, particularly in rural areas where children and elderly are most commonly affected. And as you know, it's recently emerged in southeastern Australia, affecting humans and the swine population, and seems to have become endemic in Australia, which is a huge concern for us. In terms of the transmission or amplification cycle of JEV, the main vector mosquitoes are Culex species in Australia and in PNG. The main species are thought to be Culex nalurostris and Culex gelidus, but in Southeast Asia there are many other species that can amplify the virus. The main species in Asia is Culex tritinarincus, main vector species. For vertebrate hosts, pigs are thought to be the main amplifying host, particularly domestic pigs. Feral pigs can also be involved. This is the case in Australia, and we're still not completely sure what the role of feral pigs is, but we suspect it might be both as an amplifier and a maintenance host of the virus. Water birds such as egrets and herons are also thought to be an important maintenance host and also important for introduction or reintroduction of the virus via infected migratory water birds. And there are other vertebrate species that are also thought to play roles or that have yet to be, I guess, well established in terms of their contribution to the amplification cycle of JEV, such as ducks, possums, bats, and sheep. Human and other livestock species are considered dead-end hosts in that after infection, although these animals can develop disease, they don't produce high enough levels of virus replication in the blood to then infect biting mosquitoes. So that's where the cycle stops. There has been historic evidence in PNG of JE, MV, and Kunjun. So for JV, there was serological evidence reported of infections of humans and pigs in southern PNG, Western Province, and Benamo between 1989 and 1998. Human cases of JE have also been reported in the Western Province in the 1997-98 season, as well as Port Moresby in 2004 and 2007 to 2008. And a suspected outbreak of JE in the Milne Bay area in 1997 and 98. Virus was also isolated from mosquitoes in the Western Province in the 1997-98 season. And for MV, only 2 human cases have been documented going back a very long time, 1956 and 1960. But there has been serological evidence in the lowlands region. The virus has also been isolated from mosquitoes in East Sepik, again a long time ago, 1966, but more recently in the Western Province in 1998. For Kunjun virus, there has been, again, historic evidence of year-round transmission from longitudinal serosurveys of children in Sepik going back to the 1960s, but there have been, so far, no reports of human cases and no mosquito isolates or detections. Going into this project, we had identified the following knowledge gaps for PNG. These focused on the current epidemiology of JEV and the other target zoonotic arboviruses. In particular, this included the prevalence and incidence of disease, geographic distribution, seasonality of transmission of these viruses, genotypes of circulating strains and their relationships with Australian strains, and noting that at the start of the project, the most recent isolates were made around 20 years previously. And vectors were also a gap or a question: what species are involved, and where do they circulate, and when do they circulate, and what numbers as well. The other major question we had was around disease burden. It had been recognised in the literature that clinical cases, or many clinical cases, had or do go undiagnosed or misdiagnosed as cerebral malaria or dengue. And at the time of the project started, there was also a recognition that there was limited or no laboratory testing available for JE and these other viruses. So turning to the projects themselves now. So we were very fortunate to receive funding from the Australian Centre for International Agricultural Research, or ACR, as their acronym goes. The first project was a One Health approach to establish surveillance strategies for Japanese encephalitis and zoonotic arboviruses in PNG. This ran between 2019 and 2021. The links to the final project report and one of our publications are here. This project primarily involved setting up and establishing pilot surveillance projects and the associated lab and field surveillance capacity needed for that. The second project was strengthen surveillance for vector-borne zoonotic and livestock diseases in PNG. This ran between 2023 and, in fact, that should be 2025. That finished in March this year, and we're currently working through the data and results that we've found, and we hope to report this back to ACR very soon. Now, turning to a One Health some One Health background now. What I wanted to show you is the One Health definition from the One Health high-level expert panel. And this is a definition that has been recognized and adopted by the World Health Organization and also the World Organization for Animal Health. So you can see the definitions here. One Health is an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems. It recognizes the health of humans, domestic and wild animals, plants, and the wider environment, including ecosystems, are closely linked and interdependent. And this approach mobilizes multiple sectors, disciplines, and communities at varying levels of society to work together to foster well-being and tackle threats to health and ecosystems. And you can read more on by this One Health high-level expert panel at the link that you can see there. And I'll just get my pointer going again. So One Health, importantly, and in relation to this project, has long been recognised as the optimal approach for zoonotic diseases that affect both humans and animals, and also an optimal approach for resource limited settings where equipment and staff and capabilities can be leveraged between jurisdictions and different institutes. So the broad objectives of these projects were firstly to build capacity for undertaking herbivorous surveillance using a One Health approach, and these focused on three areas. The first is or was mosquito vectors, and Joelyn will be telling you a little bit more about this after my talk. The second approach focused on sentinel animal, or particularly pig serosurveillance, and Bridgit will tell you more about this, Bridgit Fabilia from NAQIA. And finally, for the second ACR project, we included some human surveillance as well, and Hanson will tell you about the work that we've done on a cross-sectional sero-survey of human populations. The second overall objective we had for the projects was to establish and develop linkages and coordination between human and animal health agencies, and this is largely focused on those relationships between IMR and also NAQIA. So this leads nicely into the partners who were involved in this project. I led the project from the CSIRO, Australian Centre for Disease Preparedness, down in Geelong near Melbourne in Victoria. James Cook University were also involved, as well as the Burnett Institute. And in PNG, as I've already mentioned, IMR were one of our main partners in both Madang and Port Moresby, and NAQIA, particularly the National Animal Health and Food Testing Laboratory, NAFTAL, Kila were our animal health partners, both in Port Moresby and at Lae. So to summarise, we've been able to undertake targeted herbivorous surveillance from 2019 in PNG, and this has provided new insights into the circulation of J and some of the related flaviviruses I've mentioned. I guess importantly, these projects have also enabled development of laboratory and field capacity and have complemented other projects such as STRIVE. So I haven't mentioned this yet, but the ACR projects have really, I guess, operated hand in glove with STRIVE, and that's also worked quite well. I think these projects have been, I guess, a successful example of One Health cross-organisational approaches involving NAQIA, IMR, and the Australian partners that have led to enduring partnerships to build and support capacity for surveillance and lab diagnostics that we hope have and will benefit PNG's public health and biosecurity. I always get a little bit nervous when I show acknowledgement slides because I'm afraid that I've forgotten to include someone, but there are a number of people that have been involved over the last 5 or so years in these projects that I wish to thank and acknowledge. I won't go through all of the people here. The people in blue are either institutional leads or played significant roles in their particular departments, and I've also highlighted the speakers who will come next.
All right. Dr. Williams, if you are tuning in, thank you for a wonderful presentation on the overview of One Health concept and research and surveillance program that you are leading, which is critical to protecting the health of humans, animals, and the environment that we share. Dr. Williams' presentation has nicely set the stage for the next 4 presenters who will be presenting their findings on specific research projects within the One Health framework. Our next presenters are Ms. Joelyn Goi, who is a scientific officer with PNGIMR, Mr. Hansen Dima, a research officer also with IMR, and Ms. Bridgit Fabilia, a research officer with NAKIA. All 3 of them work in collaborations with Dr. David Williams' team on arbovirus surveillance. All 3 speakers will present on JE with Japanese encephalitis case studies. Please welcome Joelyn's pre-recorded presentation, which will be followed back-to-back by Hansen's pre-recorded presentation and Bridgit's presentations live from Port Moresby. Joelyn's presentations will be on Japanese encephalitis in mosquitoes. Hansen will be Japanese encephalitis in humans, and Bridgit will be on Japanese encephalitis in pigs and animals. Thank you very much, and let us now listen to their talk.
Hi and good morning, everyone. Thank you for this great opportunity to present with you all one of our many surveillance projects. I will present on behalf of our team on zoonotic arbovirus vector surveillance and molecular detection in Papua New Guinea. In Papua New Guinea, there is limited knowledge about Japanese encephalitis virus and other zoonotic arbovirus, especially regarding how common they are, where they occur, when they spread, what strains exist, and which mosquitoes carry them. Our study was conducted from 2019 to 2024 at 14 agricultural farming sites in 4 provinces in PNG: NCD, Central, Morobe, and Western Province. Our study was done in sentinel surveillance sites for the PNG National Agriculture Quarantine Inspection Authority. Our longitudinal surveillance was done in 2023 and 2024 in Central and Morobe Province. Our field surveillance method. So in the field, we set up adult mosquito traps at the piggeries. We have about 14 days of mosquito trapping per site or per piggery. So after we set that mosquito traps, we collect the mosquitoes every day for the next 14 days. So when we collect the mosquitoes, we knock them down for about 10 to 20 minutes in the freezer. Then we sort the collections by separating the mosquitoes from the non-mosquitoes, because when we collect our catch packs also come with non-mosquitoes. After we separate them or sort them out, mosquitoes from non-mosquitoes, then we discard the non-mosquitoes, and the mosquitoes, we identify them using microscope to species level. And they are blood meal, as in unfed, partially fed, and fully fed. And then we store them in RNA later, and then the mosquitoes are brought to the lab for processing. At the lab, we pull the mosquitoes again by the species, blood meal, according to the location of collection, month and year of collection, and the trap type used for collection. After that, we then homogenize the mosquitoes from the pools that we have pulled them. And then after we homogenize, we do RNA extraction, and then we run PCR. So most of our sample processing for this surveillance was done at the Mall Hub Partnership Clean Health Laboratory in Port Moresby and ACDP in Geelong. Here is our 2019 to 2021 mosquito species distribution. So from our recent publication in 2022 for this work, we compared the 3 different types of trap, the mosquito traps that we used in the poultry and piggery farms. So we compared the CDC normal light trap, CDC UV light trap, and the BGS trap, and found that the CDC UV light trap to be most effective in catching Culex specific mosquitoes in PNG farms. So from this, we collected a total of 29,920 mosquitoes from the 4 different provinces that we surveyed. And out of the 29,920 mosquitoes, 18,951 mosquitoes were Culex. In our recent longitudinal surveillance result, we conducted the surveillance in Morobe and NCD only, in piggeries only, and we used BG Pro UV light traps and BGS traps. So from these, we collected a total of 37,077 mosquitoes, and 36,710 mosquitoes were of the species of Culex. So as you can see from the results here on the graph, you can see that the BG Pro UV collected more mosquitoes than the BGS trap, and also more Culex mosquitoes. Our PCR results from 2019 to 2021 in Morobe, we detected 2 positive for JEV from Culex gelidus mosquitoes and 2 Cocobera virus from NCDO Central from Culex enolorastris and Culex quinquefasciatus mosquitoes. In Western and Medang province, we also got positives for Cocobera virus, and they were found in Culex pilus mosquitoes and Culex quinquefasciatus. So in 2019 to 2021 surveillance, we detected a total of 2 JEV and 5 Cocobera virus from the 18,951 mosquitoes that we collected. PCR results for the recent surveillance from 2023 to 2024, we detected 9 JEV positives and 2 Murray Valley encephalitis virus positives from Morobe province. So 7 Japanese encephalitis virus from Culex gelidus mosquitoes, which were like a continued detection from the first detection in 2019 to 2021. And we got the first JEV detection from Culex quinquefasciatus and Culex citians, still from Morobe province, and we got 2 JEV positives from NCD or Central from Culex gelidus mosquitoes. So altogether, we detected 11 JEV positives and 2 Murray Valley encephalitis virus from the mosquitoes that were collected from 2023 to 2024. Here is a phylogenetic tree showing the JEV sequencing for the 2 JEV positives from 2019 to 2021. So the JEV genotype belonging to the genotype 4 were confirmed from Culex gelidus mosquitoes collected from the piggery in Ley from 2019 to 2021. So the JEV genotype belonging to genotype 4 is the first detection in PNG, and it is the first time this genotype 4 has been detected in Melanesia, Australia, and New Zealand, as previously it was genotype 1 and genotype 2. So the phylogenetic analysis revealed that JV detected in PNG samples clustered with a recent large-scale JV outbreak in Australia in 2020. In summary, our study presents the first detection of JV in Culex gelidus mosquitoes from 2019 to 2021 and continued detection of JV from Culex gelidus from 2023 to 2024. It is the first time an arbovirus has been detected in zoonotic arbovirus vectors in PNG livestock farms. Our 2023 to 2024 surveillance showed continued circulation of JV, and also the first detection of JV from Culex gelidus mosquitoes from Central Province. Also a first detection of JV from Culex quinquefasciatus and Culex citians, and the first detection of Murray Valley encephalitis virus in Culex gelidus mosquitoes in Papua New Guinea. Our study highlights the biosecurity and public health risk that JEV and MVEV poses in PNG, and especially in communities of our sampling locations, and it highlights the importance of a One Health approach with PNG cross-sector and regional collaboration to facilitate surveillance and control of cross-border zoonotic pathogen threats. Thank you. We acknowledge all organizations who have worked with us and has been part of our surveillance work. Thank you. That's the end of my presentation.
Highlighting it as a potentially important genetic risk for our population. Current surveillance system in the country does not include JEV surveillance, thus there is a lack of data to provide insights on the epidemiology of JEV as well as its impact on human health and human livelihood. This project aims to determine the prevalence of JE in populations within living within and around selected piggeries in Morobe and the National Capital District. Methodology: a cross-sectional survey was carried out across 5 different farms in Morobe and the National Capital District. In Morobe, 2 farms were selected, including Rumion and EBC. In NCD, 3 farms were selected, including Boroma, Eden Green, and Rideau. Our study population mostly or mainly included farm workers, their families, and community members who were living in or around the farm areas. Study age group include 0.5 years or individuals who were 6 months and above. For the study procedures, a community engagement and talk survey exercise was carried out prior to the recruitment. Those willing and meet the exclusion criteria were consented and recruited. A fingerstick blood sample was collected for all participants for laboratory testing and analysis. Serological testing using competitive ELISA to detect antibodies to JV, along with closely related Mammary-Valiant encephalitis and conjugated virus, also known to circulate in PNG and cross-react with J. This was done as a routine to identify cross-reactivity or non-specific results. Preliminary results. A total of 362 participants was recruited. The table here shows the breakup in numbers for each farms, as well as the gender and the age group that were recruited. Seropositivity for JV. Of the 362 tests that was done, 24% were tested positive for JV in the first screening. However, confirmatory testing is still ongoing. Also, 0.3% of total individuals recruited reported to have been vaccinated against JE. 24% do not use mosquito nets or bed nets at night. In conclusion, initial screening shows evidence of JEV. However, confirmatory laboratory testing is ongoing to confirm these observations. Preliminary field results or field survey data highlights factors that increase the transmission of JE are present within the communities. Understanding these factors and the presence of JE will provide baseline data for future work and also the strategies for mitigating the risk of JEV outbreak in Papua New Guinea. We would like to acknowledge, sincerely acknowledge our funders for this project and stakeholders involved. We also thank the farm managers for the respective pig farms, farm community and individuals who participated, and the study team. Thank you.
Okay. Am I on?
Yep.
Okay. So we have just had 2 talks by Joelyn and Hansen. We are now waiting to hear from Bridgit. So Bridgit, if you are ready to go, please go ahead and start sharing live from where you are in Port Moresby. Okay. Well, I just want to let the audience know that we will be going for lunch break soon at about 12:40, if we can make it quick, but that's just giving you a heads up. And also, please, if you have questions, don't forget to post those comments in the chat.
Yeah, that's what Moses says.
you for having Nakia here. My apologies, my short presentation won't be as exciting as everyone else. I'm still recovering, so that's why I'm sitting down. So I won't be as exciting as everyone else, but although my facial expressions won't show it, Nakia is very happy to be here, and we're very thankful for the partnership with PNGIMR, ACDP, as well as the rest of the molecular hub, and with the continued support with DFAT. So I'll be discussing the animal surveillance part. I work with Nakia, as has been already mentioned. I was part of the first phase as well as the second phase. So the animal surveillance was done in 2019. That was the pilot surveillance, which was done by Nakia for the animal side. Pigs and chickens were sampled at that time, and it was from the villages as well as from the farms. There are about 10 sentinel sites in the 3 provinces, the National Capital District, Central, as well as Morobe. There were multiple rounds that were done over a period of time, between 2 to 6 months. However, there was inconsistent sampling because it's done in the villages as well, and there was not much control. You can't control if a pig is already healthy and live and ready for sale. So that is why there was inconsistency with sampling. Example as the number of animals sampled, frequency, and the timing varied. So at that time, only serum was tested for the animal samples for the evidence of seroconversion or sero-prevalence for flaviviruses, for JEV, MBE, as well as Kunjin. The testing at that time was done at ACDP as well as Nakia. Competitive ELISAs were done. The bottom picture, it shows private owners being explained about the project by Dr. David Williams, about the sampling that would be involved, the potential risk to animals. We know how valuable pigs are in Papua New Guinea, so it's very important that they understand the risks involved, and the need to conform with the Australian Code for Care and the use of animals for scientific purposes, along with their responsibilities for feeding, monitoring, husbandry, as well as providing adequate accommodation. So the pictures that are shown here is to at least give you a scene of the various sentinel sites that were done in villages as well as the commercial farms. So you can see the typical scenario for how pigs are kept along the coastlines for the central province. And we've got a commercial piggery farm at the back there. We'd like to give acknowledgement to Mr. Pius Clement from NACIA for leading the Port Moresby team, as well as Dr. Ian Enriquez and Mr. Henny Negani for leading the NACIA team. So this slide shows representatives results, representative results from the 2019 and 2020 survey for serology flavivirus ELISAs. The blue shows the JE positive, yellow for MBEV, and light blue for Kunjin, and the orange for unresolved, where there may have been more than one flavivirus. And for the gray is negative. For Morobe, we've got Brumion show the highest levels of JEB seropositivity, but high levels were also found in NCD and Central in September and November. There was some evidence of MBE in chickens from the city mission, but at low levels. Pigs were observed to be a more sensitive sentinel compared to chickens. Therefore, in the second phase, chickens were no longer used in the study, and the focus was mostly on pigs. So for the animal surveillance for the second phase, once again, both Port Moresby and lay teams were used. However, this time the focus was on commercial piggeries. And there was a monthly collection that was done over a period of 1 year, August 2023 to July 2024. Serum was tested for evidence of seroconversion, and this time oral fluids were also collected for direct PCR detection of JEB by NAPTEL, but performed, the testing was done by NAPTEL staff, but at PNGIMR. This time, a more systematic approach was designed by Dr. David Williams to see if we could detect seroconversion in weaning. So, as mentioned, serum was collected monthly from cohorts of weaners. These are the younger piglets that are between the ages of 8 to 10 weeks, weaning maternal antibodies and subsequent seroconversion from natural infection. This is only for Port Moresby, for NCD. There were mostly JEB specific reactors. Cross reactions were typically resolved. Only one cohort showed clear evidence of seroconversion and did not coincide with the peak mosquito abundance in December. There was a high percentage of reactors in February to March, which was consistent with the virus isolation from the mosquitoes in February. The preliminary analysis showed sero-prevalence of about 10 to 100% across 4 cohorts that were sampled in NCD, with seroconversion evident between September and October 2023. The highest levels of seropositivity were found between December 2023 and April 2024. The majority of antibody positive samples tested were resolved as JEB specific, which indicates that JEB was the more dominant flavivirus circulating around during these times. For the oral fluid sample for JEB, the samples were processed at NAPTEL, and as mentioned, it was tested at PNGIMR. There are about 11 times monthly samples from both Morobe as well as NCD. Interestingly, although we got results for the antibody results with the ELISAs, all JEB PCR results were all negative. Possible explanations are that there may have been low levels or no JEB circulating prior to the collection times. The sampling window may not have been optimal because the virus sheds between 4 to 5 days. And there was also consideration with possible PCR inhibitors in the sample. This is myself using the facilities up at PNGIMR to do the JEB testing through PNGIMR. This has set that this ended up being the first time that Nakia has had Nakia PCR capacity. And from what we started off with African swine fever at the time that we had the outbreak, we have now expanded through PNGIMR, the molecular hub, where we have now got foot and mouth disease, lumpy skin disease, as well as now Japanese encephalitis virus. I would like to make acknowledgement to Ms. Tamara Koliala and her team, and Ms. Rosemary Simbil, and Burnett, Professor Leanne Robinson, and Ms. Rebecca Narakubi. So here we have some of the staff that I moved in from our lead team for the JEB animal sample collection and testing, as well as Port Moresby. And we've got 2 of our staff from NAFTEL that are testing the sample, including 1 ACDP staff that is Port Moresby based. And in the center, we've got one of our Nakia animal health officers, plant health officers, as well as PNGIMR doing awareness before the surveillance was done. With that, I'd like to thank you all very much for tuning in. I also had a second presentation, but due to time limitations, I won't present that. And that was based on the One Health collaboration between PNGIMR and Nakia. But thank you very much.
Okay. Okay, are we on? Excellent. So thank you very much to Joelyn, Hansen, and Bridgit for wonderful presentation for the 3 nicely executed JE case studies. I'm sure this is immensely valuable findings, which I'm pretty sure it updates and advances our knowledge on the JE virus ecology and transmission in PNG. So the 4 preceding talks shed light on the presence of zoonotic arboviruses and the mosquito vectors that transmit them in PNG. Equally important to the arbovirus system is what environment are they likely to persist and what happens when the environment is disturbed or transformed. So in these next presentations, I will discuss the effect of land use change on mosquito vector ecology with a focus on large-scale oil palm plantation industry. So mosquito species vary in their affinity for types of habitats due to differential adaptive evolution, particularly the aquatic habitats where the larvae breed. The availability, abundance, and distributions of habitat types in the environment determines the presence, the abundance, and distributions of mosquito vector species. Therefore, large-scale alteration of land surfaces, often referred to as land use change, for agriculture, extraction, for mineral extractions, or logging industries affects the availability and distribution of mosquito habitats. Such changes affect mosquito vector ecology and disease transmission potential in the environment. In this talk, I'm going to refer to two major groups of mosquitoes. I'm going to refer to Anophelines and Culicins. Anophelines are all mosquito species within the genus Anopheles, and Culicins are all mosquito species outside of the Anopheles genus. In PNG, Anophelines are vectors of malaria and filariasis, whereas Culicins transmits arboviruses such as dengue, Japanese encephalitis, and chikungunya. The objective of the study was to investigate the hypothesis that land use change for oil palm plantation alters the ecology of mosquito vectors in the impacted areas compared to long-standing natural forested areas. The significance of this study is that such changes in mosquito ecology can affect the transmission potential of vector-borne pathogens, which may increase or decrease the risk of infections in populations in impacted areas. So to test this hypothesis, we collected mosquitoes in 6 different sites in the Ramu oil palm plantation. For those who may not know, this plantation is located in the Makam Valley, PNG. Okay, so what we did was we collected mosquitoes in 3 villages or human settlements inside the oil palm plantation, as you can see on the map here. And then we also collected mosquitoes in 3 other sites outside of the oil palm plantations. And we collected mosquitoes using the same 2 methods that I discussed in my previous talk. And we also did 3 collections, 3 nights of collections in each of those study sites. So now to the results. So if you look at the plot on your left, that shows you the proportion of all the mosquitoes according to the genus Anopheles, Aedes, Culex, and other that were encountered in the natural forest or in the oil palm plantation. Now, what you can see in Figure A is that most Anophelines, okay, 91% of Anophelines were collected outside of the oil palm plantation, whereas most Culicins here are Aedes, Culex, and other species. Most of them, 72 to 89%, were collected inside the plantation. Okay, so there is sort of an association of the different genus of mosquitoes to these 2 environments. And the differential association of the mosquito groups to the plantations and natural forest was supported statistically by logistic regression, and as you can see in the odds ratio plot in Figure B. We also calculated the mosquito biting rate in the 2 environments for Anopheles, Aedes, and Culex mosquitoes. The biting rate is the number of bites per person night. Okay, so the biting rate of Anophelines was significantly greater in the natural than impacted environments. Okay, and for Culicins, it shows the opposite, where the biting rate was higher in the oil palm plantation compared to the natural forest, undisturbed environment. So in conclusion, the conversion of native forest environments to oil palm plantation reduces the abundance and biting rate of Anophelines, but it increases that of the Culicin mosquitoes. Okay, and while conversion of native forest to oil palm plantation reduces the risk of malaria, which is a treatable disease, it increases the risk of arboviruses, which do not yet have antiviral treatments, and for most of them, vaccines. So these findings underscore the importance of research to understand public health consequences of large-scale anthropogenic environmental change, in particular vector-borne diseases. So I would like to thank all the contributors for this project, and most importantly, the 2 funding institutions, which is the Global Institute for Disease Elimination and the Asia Pacific Malaria Elimination Network. Thank you very much. Okay, a reminder to live stream groups for those in especially IMR or other institutions that are streaming in live, working as groups. Please write down your questions and pass it to whoever IMR staff that is hosting, and then they can post your questions to us. And in the interest of time, we are running out of time. We will not be. Yeah, we will go straight to lunch, and the next talk by Dr. Neuendorf will be afterwards, after the lunch. Yeah. Okay. And yes, thank you very much. And this ends the session for the One Health and climate change session. So thank you very much. We'll come back after lunch and see you.
Welcome back to our virtual symposium. I hope you had a great lunch and break. If you just joined us, I am Gwendalyn Vengiau, and I'm co-hosting today's virtual symposium with Dr. Keven and our director, Professor Pomat. Before we start our afternoon session, I would like to do some quick shout outs to especially IMR staff joining in from our other sites, in Madang at Madang Resort Conference Room, and in Niagam, those with them New Guinea and Madang Fire Service, in POM in Lamana, and the PNGIMR Partnership in Health Lab, Goroka in the IMR Adolph Saori Lecture Theatre. Would like to acknowledge Oxfam and UG, as well as the Goroka Provincial Hospital staff. In Kokopo, the PNGIMR staff and our other stakeholders, Burnett Institute and East New Britain PHA, Mustard Seed, and also a very special shout out to Solomon Islands and Fiji who are tuning in to our virtual symposium.
Yeah. Thanks,
Dr. Keven.
Okay, thank you very much, everybody, for tuning back in after lunch. I hope, like I'm repeating Gwen here, for the nice lunch. So we were supposed to have a presentation by Dr. Nalisa Neuendorf, but that will not be happening now because of time. We'll make her presentation available, I think, later on in the, after the symposium. There will be some postings from this event that will include her slide as well. So we will move on now to the talk by Dr. Ian Umo, and then afterwards there will be question and answer session for the first session on One Health and climate change, and after that we will be switching over to the session, then the next session following the One Health and climate change. Okay, so Dr. Ian Umo is a surgical registrar who is studying a Master of General Surgery at Port Moresby General Hospital. Okay, he is passionate about combining research and clinical practice and has a strong interest in clinical service delivery, strengthening health systems, and health economics and climate change in surgery. Most of his research is conducted at Alotau Provincial Hospitals, where he has worked for the last 5 years. So, ladies and gentlemen, please welcome Dr. Ian Umo.
Hello, everyone. Thank you very much for having me present at this year's annual virtual symposium. The topic of my presentation is on estimating the carbon emissions from a resource-limited surgical suit in Papua New Guinea. I have no conflict of interest to declare. Now, climate change has been described to be one of the biggest health threats in the 21st century, and this is as a result of carbon emissions. As you can see, after the 1900s, because of industrialization and increase in human activity, there's been a sharp increase in carbon dioxide emissions globally. And the health sector contributes about 4.9% of the total global greenhouse gas emissions. Within the health sector, one of the main sources of these emissions come from the operating theater. Now, the rationale is that according to the Lancet Commission of Global Surgery, there is a huge unmet burden of surgery in low to middle income countries. And if we increase surgical services in those low to middle income countries, we would indirectly increase carbon emissions from the health sector, and that would increase our emissions from 4.9% to 5 or 6 or 7%. Now, at the time of the study, there was no data on how much carbon emissions were actually coming from operating theaters in low to middle income countries. As such, this study aimed to estimate the carbon emissions from an operating theater in Alata Provincial Hospital in a resource-limited setting. This was a prospective carbon footprint study over a period of 3 months. We reported the carbon footprint in terms of the greenhouse gas protocol. So we reported it in terms of 3 scopes. Scope 1 looked at direct emissions. Scope 2, indirect emissions from energy consumption. And Scope 3 were emissions from the consequences of the activities within the operating theater. So we basically estimated emissions for anesthetic gases, electricity consumption, and Scope 3 waste disposal emissions. This study was approved by the Research and Ethics Committee of Alata Provincial Hospital. There was no funding or grants received for this project. Over the study period, we had a total of 316 operations that were done. These were mainly done under general anesthesia and local anesthesia. And when you look at the emissions from the 3 different scopes, the two main inhalation anesthetic gases that we used were isoflurane and halothane, the most common being isoflurane, and they had a total emission of about 1.1 ton of carbon dioxide equivalent, and that's the same amount that would be emitted by a land cruiser if it were to travel from Leh to Mount Hagen 7 times. Now, in terms of electricity consumption, in this study we emitted about 553.8 kilograms of carbon dioxide equivalent. In terms of waste disposal, all our waste were landfill, they were not incinerated. Most of the emissions came from transportation of this waste, followed by sharps, polypropylene, and average plastic. So in total, we had a total carbon emissions for Scope 3 to be about 894 kilograms of carbon dioxide equivalent. So from the study, we can see that within the operating theater, the major source of greenhouse gas emissions or carbon dioxide emission were from anesthetic gases. On average, per surgery, we would emit about 8.3 kilograms of carbon dioxide equivalent. And in total, over the study period, we had emitted about 2.6 tons of carbon dioxide equivalent. That's the same amount a passenger jet would give off if it traveled from New York to France twice. Now, this was the first study done in a low to middle income country looking at the carbon footprint of an operating theater. Prior to that, a study by McNeil, Lillywhite, and Brown also looked at the carbon footprint of 3 operating theaters in a high-income setting in US, Canada, and the United Kingdom. Now, compared to that study, operating theaters in high-income countries, they emit about more than 400 times more emissions from anesthetic gases compared to our study. In terms of energy consumption, they would emit 316 times more emissions from their electricity usage and energy usage compared to our study. In terms of waste disposal, 1,000 times higher emissions compared to our study. Now, of the anesthetic gases, desflurane is the most potent. It has a global warming potential of 2,540. Basically, it can trap heat 2,540 times more compared to carbon dioxide. And in 2014, 80% of all the inhalation gases that were emitted into the atmosphere were that of desflurane. And its use is actually limited in low to middle income countries like PNG because of its high cost. We use instead halothane, isoflurane, and other gases. Now, we do not have a scavenging system in our operating theater, and that poses a certain occupational health risk. There have been various studies showing that health workers continuously exposed to anesthetic gases in a setting of no scavenging system at high risk of developing spontaneous abortions, congenital abnormalities, and cancers. Now, the healthcare facility is a facility that uses a lot of energy because we're continuously looking after patients. And in terms of electricity generation in PNG, 37.3% of energy production is as a result of diesel generation. And I say this because there's a lot of potential for us to utilize our renewable resources, especially geothermal energy, hydroelectricity, and solar forms of energy. Now, all the waste in this study were landfill. They were not incinerated or treated. And this poses environmental health risk in that you have carcinogens like dioxin and heavy metals or radioactive substances that leak into the surrounding environment. They pollute the environment. And from that environment, we are gardening and we are fishing and we consume from the environment again. So in polluting the environment, we are polluting ourselves also. Now, our recommendations are that we reduce the use of anesthetic volatile gases. We encourage more regional anesthesia and TVET. We should install scavenging systems in all our operating theaters. We should invest in renewable energy. We should properly treat our medical waste. Think about using more green-friendly medical consumables. And our limitation is that the local emission factors that we used in calculating these carbon emissions were not from Papua New Guinea, but from other countries, because these emission factors are supposed to be given by the government, but we had to source these emission factors from other studies and countries. So this study does not represent other operating theaters in Papua New Guinea. I believe we have to do a separate study to see how much carbon dioxide equivalence is being emitted from Port Moresby General Hospital, so to say. To conclude, climate change affects us all. As health workers, we must play our part in the health sector to reduce our impact on the environment. Thank you.
All right, thank you very much for a wonderful talk by Dr. Ian Umo. We will now move on to the Q&A session to end the session on One Health and climate change. So I'm going to pull up the slide that we have here with listing the two questions. Are we able to see this? Okay, so I think that I'm going to read a question, and then Dr. Williams, myself, and Gwen can try to tackle these questions. So the first question is from the first series of questions, interrelated questions, from somebody from Kokopo. And the question goes like this: apart from the samples collected from the animals, what are other samples apart from the blood samples? Okay, this is with regard to the JEV studies. I think it's directed to the three presenters and Dr. Williams for your talk on JEV. Okay, and then are there any vaccines available for JEV? That's an interesting question. I would like to know too. If the pigs were affected, what do we do? Okay, or what do you do? What is the management for infected pigs? Okay, that's the first question. And the second question is from somebody from Solomon Island. And the question goes, what is the type of vector control measures that can be used for prevention of JEV? And what is the peak period for JEV vectors? Okay, so let's try. I think I'm going to give the opportunity to Dr. Williams to try to tackle some, and I can help where I can.
Okay, thank you. Thank you for such great questions. So maybe starting from the top then, apart from the samples collected from animals, what are other samples apart from blood samples? So for animals, as Bridgit mentioned, we also tried collecting and testing oral fluids from pigs for the most recent project. This has been shown experimentally to be a useful technique for direct detection of JEV, because pigs are known to shed virus through their saliva, and they can actually transmit between each other via infected oral shedding. However, as you saw, that wasn't very successful in the pilot study we performed, but as Joelyn mentioned, that may be because we don't quite have that sampling approach optimized yet. Another method that has been trialed quite successfully in Australia is to sample effluent from piggeries as well. This effluent can contain can contain infectious material from JEV that's also shed from pigs in their saliva, in their urine and feces. And so that's been a really useful, I guess, low impact sample to collect. You don't need to interact with the pigs for that. You can collect them from effluent ponds. So I might move to the next question then. Are there any vaccines available for JEV? Yes, there are, and very good vaccines for both humans and pigs and horses for that matter. For humans, there are two main vaccines that are available in Australia. One is Imagev, which is a chimeric vaccine it's made up of, it's a recombinant vaccine that has a yellow fever backbone and the JE structural proteins, where all of the immunologically reactive proteins exist. The other one is JE-SPECT. That's an inactivated vaccine, a virocell inactivated vaccine. So they're certainly available. They're at the moment usually given to at-risk individuals or communities. And in the past, for example, they were also provided to residents of the Torres Strait Island in terms of the Australian, I guess, vaccine rollout and public health measures. For swine, the vaccine is not often used, particularly for grower pigs, because there's really only a short window of effective immunity for grower pigs, which is about 3 months, and most farmers don't choose to I guess accept that cost of having to vaccinate all of their animals. Instead, what usually happens is they focus on sows, and the sows can provide protective immunity to their offspring and provide 3 or 4 months protection through maternal immunity. That's not done everywhere though. Japan and Taiwan are probably two notable countries that do that. It's not something that we've yet undertaken in Australia. So as you know, JE has emerged in the southeastern states where there is a lot of pig production, but it is something that the industry is very much interested in and we're moving towards. Horse vaccination is also undertaken, but generally around the world, not just in Australia. That's done for race horses or high value horses that are moving into or going to race meets in JE endemic countries. I'll move on to the next one, if that's okay. So if the pigs were affected, what do you do? That's a great question. So typically most pigs don't show any clinical signs, so it's not like an infection of humans. However, where disease can be found is for pregnant sows that become infected. So in those instances, and this is what we saw in Australia and still see, there can be reproductive disease. So that presents as aborted litters, mummified litters. Weak pigs are born with neurological signs that die soon after. And that can have a big effect on the industry as well. It certainly had a major economic impact for the 2022 outbreak in Australia. Unfortunately, there's not much you can do once the pig becomes infected, but as I said, there are swine vaccines available that can be used to mitigate or prevent infection in the first place. What is the management for infected pigs? I think I've probably just answered that. Unfortunately, little we can do. I might move on to the next question, if that's all right. What is the type of vector control measures that can be used for prevention of JEV? These measures would, I think, be similar to vector control measures for other mosquito-borne or vector-borne diseases. Things like insecticide treatments, fogging, use of chemicals, bed nets, wearing long sleeve clothes at dusk and dawn, using personal insecticide sprays to prevent mosquitoes from biting you. On farms, there's also an approach called integrated vector management, and that involves chemical treatment and insecticide treatment of the farm itself, active removal of vector breeding sites, so ponds and standing water and that sort of thing. Now, what are the peak periods for JE vectors? That's a really good question, and I guess that's a question where we've been working towards answering through the ACR projects, and Joelyn showed some data on that. I'm just going to refer to some graphs so I can sound a bit more sensible. So from the most recent study that Joelyn led, where we were looking at temporal abundance across a 12-month period, what we found was for the Morobe province, peak abundance numbers were that happened around May or April. There are also fairly high numbers in August as well. We saw a different story in Port Moresby, where peak numbers were in December. And so for Port Moresby and NCD, that corresponds with rainfall. So as you know, there's the rainy season starts in around November, December, and that seems to correspond with peak numbers of mosquitoes. Whereas in Ley, rainy Ley, it's wet all year round. So it's a little curious that we're seeing those peaks. Why not see a sort of a flat level of abundance the whole year round? That's something that I'm not sure about. Joelyn and Stephan and others involved may have their own take on that as well.
Okay, so one last question, and then we can move on because we are running out of time. And there are several questions that we have here, but we will respond to those questions individually and then post it in the chat. So do you think that JE transmission in pigs and humans is increasing now recently compared to past surveys, if you have any data on surveys from before?
Another great question, and it's I think we're not yet in a position to answer that accurately. I think we've really only undertaken I guess 2 rounds of surveillance, and the first project was really about implementing pilot surveillance capacity and building up our expertise. I think through the second project, we're getting a better handle on, well, at least sero-prevalence patterns in animals and mosquito abundance, as I've just discussed. What we still don't have a good handle on is the disease in human populations. So the most recent project has given us some insight into sero-prevalence. Some of the data that wasn't shown included PCR testing of dried blood spots that were collected as part of the STRIVE febrile disease surveillance. And we didn't find any positives from those, but the important thing to, I guess, keep in mind is that when humans become infected, they don't produce high levels of viremia. So we wouldn't normally expect to see positive blood samples for JV. That would be rare, I think. So I think that we need to, I guess, look at that more closely in terms of how we undertake human surveillance, and that certainly will be a question for future projects. And I apologize, my voice is starting to go. I've been nursing an influenza infection, a non-vector-borne disease all week, and it's just starting to give way.
Okay, thank you very much, Dr. Williams. And that ends our Q&A session. Like I said, we will post your questions, respond to your questions in a post later on. And also it ends the session on climate change and One Health. We shall now move on to the next session. And it's over to you now, Dr. Gwen and Prof. Pomat. You two can take it on from here. Thanks, everybody.
Thank you, Dr. Keven, for moderating and leading the Climate Change, Health, and One Health Systems session. And thank you to all our presenters. They were very insightful presentations. I would like to now welcome back our director, Professor William Pomat.
All right, thank you for having me back, and I hope you all had a good lunch. not too filling because we don't want you to drop off to sleep. So keep vigilant. And this next session is in memory of Michael. So Michael, for those of you who don't know, Professor Michael Alpers was the director of the Papua New Guinea Institute of Medical Research from 1977 to 2000. So, I mean, 23 years he served as the director of the institute, and he's the longest serving, or he is the longest serving director of the institute. Michael first arrived in Papua New Guinea in the 1960s to work on Kuru, a neurodegenerative disease that was affecting the people of Foray in the Okapa district of Eastern Highlands. The intrigues and stories and evidence that he and colleagues gathered not only helped to understand the disease, but also helped to save the population of Okapa. In 1977, he took on the reign as the director of the institute, and which he served, as I previously said, for 23 years. He started with 10 staff, 10 expats, 5 expats and 5 local staff. Today, we have more than 380 staff. And so he has built a legacy for us at the Institute, and he's built the scientific, not only the Kuru project program, but also the scientific program of the Institute over those 23 years. One of his legacies is, of course, the Buttressing Coalition, which currently is funding this program, and is the partnership that we have between ourselves and many organizations in Australia, in Switzerland, in the US, and so on. So we're very grateful for Michael for coming up with the concept of the Buttressing Coalition as a partnership thing that celebrates collaborations between different institutions and to share our shared strengths to make sure that the research works well. Michael had a motto that he used, that there is no research without service, and there is no service without research. To this day, that motto holds true. Michael died last year in December. I was lucky enough to be able to attend his funeral, but also his birthday. He turned 90 years of age in August of 2024, and he died in December of 2024. So we are very grateful at the Institute for having Michael as the director, but also a long-serving supporter and mentor for many of us, Papua New Guineans, but also a lot of other students around the world, and a lot of many, many more scientists. Michael leaves behind his very, very best friend, Deborah, who I know is online at the moment and listening or watching these videos. So thank you, Deborah, for your time as well. He also leaves behind 4 children, 6 grandchildren, and 3 great-grandchildren. We are proud of his legacy in setting up the Institute. We will continue to see that legacy through, and as Papua New Guinea celebrates its 50 years this year, we hope that that legacy continues for us to step on the shoulders he had built for the next 50 years. So to Michael, rest in peace, and as they say in Okapa, pigowe.
I knew Michael Alpers when I started work in February 1991 with the PNG Institute of Medical Research. One thing that amazes me as I speak now was the reporters he had from Okapa. He would ask me to order their stationery and diaries. They would come in filled with their muddy mountain bags and boots. He would come to the reception and welcome them with a smile, talk softly, bring them to his office and chat with them. Hence, he would supply them their stationery, diaries, and they leave for field work. I never understood why they came to see him. I would hear that they were his reporters for Kuru project based in Okapa. He saw his reporters or field officers as important for his Kuru work. He had the hearts for such. Michael Alpers was a man of unique character.
Hello everyone. The first time I met Michael was along the Vector Lab corridor. I was surprised that he already knew my name because he called me by my name and introduced himself to me, a new staff at the Institute at that time. As he was leaving, late Audrey whispered, "That's the director of the Institute." I used to live in one of the units near the institute when Michael was the director of the institute. He comes to work very early when we are still asleep and leaves when we are already in bed, and that was his routine. He was a hard-working man, full of wisdom, intelligent, humble, and caring. Late Michael Alpers, known as Papa Michael at PNGIMR, and others who knew him, had a unique personality, his smiles, his way of addressing people as individuals. Papa Michael was a respectable person, yet does not show anyone that he was such a person. I personally admire late Papa Michael for the courage that he had in the early days when he left the shores of Australia, his home and his family, to come to PNG, where he worked and lived among a group of untouched natives of Papua New Guinea. Papa Michael, you had a type of smile that heals and restores souls, and you also had a way of seeing the potential in others, even when they don't see it themselves. I salute you and rest in peace.
I still remember Michael. Back in 90s, Michael made an official visit to IMR branch Tari, and when I arrived at the office, he asked staff out there, "Where is Sunri?" and to tell him that he's doing the traditional wedding at this village. Okay, let's go and visit him. With some of the IMR staff, they walked through the muddy drainage and came to the village where we are having the wedding feast. We welcomed them and shared a meal together. My family were very happy to see a white man came to the village and celebrate the wedding together. When Michael was passed away, I mentioned to them that the white man who came to the village during the wedding was died. They all were very sad. This is one of the events that I still remember.
Thank you so much to our long-serving staff here at IMR to share their wonderful fond memories of Emeritus Professor Michael Alpers. Michael Alpers is dear to us here at IMR and will always be. And now we'll be able to go into our next session on COVID-19. In 2020, the world was hit with COVID-19 pandemic. Testing pandemic preparedness and response in developing countries like PNG is very difficult. This next session, we will understand how the pandemic affected children's health and learn about nationwide sero-surveillance of immune response to the virus that causes COVID-19. It is now my also great pleasure to introduce Rebecca Emori. Is a senior public health scientist here at IMR and has been working for the Institute for 2 decades. She's currently undertaking her PhD at the University of Wollongong in Australia on the Australian Award Scholarship. Her doctorate research examines child's mortality, factors, disease burden, immunization coverage, and impact of COVID-19 on childhood nutrition in PNG. Rebecca's PhD project aims to improve the health and well-being of young children in PNG through evidence-based research, policy, and intervention. I hope, Rebecca, you're online, and thank you. This is the spotlight on Rebecca Emori.
Hi, everyone. I'm Rebecca Emori, and I am delighted to present to you the spotlight titled The Impact of COVID-19 on Child Health, a focus on child nutrition in Papua New Guinea. According to WHO, the first 1,000 days from conception to age 2 are critical for lifelong well-being. Proper nutrition during this window significantly impacts growth, immunity, and brain development. UNICEF states that good nutrition is essential for child survival and development, which empowers children to learn and contribute to society. Looking at the current trends in child malnutrition, for stunting, globally it's 23%, in PNG it's 50%. For wasting, globally 7%, and in PNG is 14%. And for overweight, globally it's 6%, and in PNG it's 14%. What happened during COVID-19 in PNG? The impact of COVID-19 was evident. PNG's first case on 20 March 2020 led to a state of emergency and lockdown. During this period, families faced food access challenges due to job losses, disrupted food supply chains, and rising food prices worsening child nutrition problems. PNGIMR's CHESS project study by Silas et al. Found that during the COVID-19 pandemic, household food insecurity doubled from 11% in 2018 to 20% in 2020, with the highest 35% in Central Province among the 6 provinces that we conducted our study. Looking at child nutrition and the impact of COVID-19, my PhD study compares pre and during COVID-19 pandemic nutrition to assess the impact on children's diets in Eastern Highlands Province. This study is part of the PNGIMR CHESS surveillance system. We had 2 data collection tools that we used for the study, which was Children Under 5 questionnaire with a sample size of 399, targeting age group 3 to 4 years old before COVID. The second data collection tool is the Sunrise International Study of 24-hour movement behaviors in early years, with a sample size of 168, targeting children 3 to 4 years during COVID-19. For our data analysis, we used SPSS and descriptive statistics were applied. And lastly, the key variables that we had were 4 dietary questions used, and we used scores to look at the proportion of diet of food intake among children. Looking at our results, for children 3 to 4 years old in Eastern Highlands, the type of food that they consumed before COVID, grains and roots and tubers was 92%, and during COVID, it was 97%. For greens, vegetables, and vitamin A rich food, before COVID, 93% consumed that, and during COVID, 94% of children consumed that. For fruits, nuts, and legumes, before COVID, 52% consumed that, and during COVID, 40% consumed that. For fresh protein, which include meat, chicken, fish, and pork, before COVID, 23% consumed that, and during COVID, 11% consumed that. Our study revealed that COVID-19 and lockdown measures had mixed effects on child nutrition in PNG, with both positive and negative impacts observed. Because child nutrition is very important, based on our research, we recommend that PNG needs long-term tracking of childhood nutrition and dietary trends, which can build strong public health systems and improve child health outcomes over time in the country. This brings me to the end of my presentation. I thank you all for listening.
Thank you, Rebecca Emori, for your presentation that highlights the impact of COVID-19 on children. And now I would like to hand over back to Professor Pomat to introduce our next session.
Thank you, Gwen, and thank you everyone again for listening in, and thank you to Rebecca for giving us the leeway into the impacts of COVID, not only on health, but also on nutrition, well, on nutrition generally. The next session is going to be about COVID. Many of you will know already that COVID hit Papua New Guinea in March of 2020, and it caused a lot of problems for us. Luckily, we didn't record that many deaths, but one of the reasons that the IMR was able to then conduct studies was to see how many people have converted immunologically to exposure to COVID. And so there were a couple of surveys that the IMR ran. One was during the early days of COVID throughout PNG, and the second one most recently post-COVID. So I will leave this session to Professor Moses Laman and Dr. Maria Ome, who conducted the study and who will tell us a little bit more about what they've done, what will be done, and what the impact of COVID was during that time and how we can improve on it. So I'll hand you over to Moses at the Lamana Hotel.
My name is Maria. Ome-Kaius is my surname, and I am a senior research clinician at PNGIMR, currently leading the vector-borne diseases as the research unit head, and I'm based in Port Moresby. So we have been conducting this COVID-19 sero survey since the pandemic in 2020. At the initial stages of the COVID pandemic, PNG reported its first case on the 20th of March 2020. And since then, we had about 8 cases, and they were of sporadic transmission, meaning that they were just from certain provinces and not having a focal transmission. They were affecting mostly the young age groups. And so at that time, the question was around, was COVID here and we were not aware of it, or maybe COVID entered, but because of our lack of testing capacities, we were probably not able to capture those cases. And just because PNG is a country where we see a lot of comorbidities, infections, and there was a kind of a hypothesis that maybe we were immune to it and therefore we're just seeing a low number. But after those initial 8 cases, there was kind of drastic change in the transmission of the SARS-CoV-2 or COVID-19, where the country experienced several surges. And in the third surge, there was high number of admissions and deaths. And so it was assumed that there was high exposure to COVID-19, but we needed the data to kind of confirm that. And serosurveillance is the only way where we can collect blood and assess through antibody testing in the lab to find out if someone was previously exposed to COVID. And so that data was important to let us know across the country how the extent of exposure to SARS-CoV-2 might look like. And so that's kind of where PNGIMR, with partnership with the NDOH and provincial health authorities, took on this study, the COVID sero survey, to assess the extent of this exposure amongst the health workers who are considered the frontliners and important people in the health systems, but also compare it to how the exposure was like in the community.
Okay, so while waiting for the Port Moresby folks to hook up, we can answer some of the other pending questions. Okay, there was one question from a Goroka team, which was that were there any confounding factors present that would interfere with the association of land use and presence of the different mosquito species in both types of land use? If so, how were these factors controlled? That was my question, I believe, directed at me. So my response to that is that we did our best to conduct what is called a balanced sampling design, in which the same sampling effort was done in all sampling sites, so that there may not be, we tried as much as possible to eliminate any potential confounding factors. And because we did that study simultaneously, any short-term or temporal variations within that study period would have been taken care of as well, unless there is something I'm not thinking about. But in terms of the annual variations, there could be a situation where the mosquito abundance varies over time during the perennial period. Okay, so maybe like in January, the mosquito abundance in let's say anopheline abundance would be higher in the oil palm plantation, and then in December it goes down. That is there, that's possible, but that would require what is called a longitudinal mosquito surveillance program from beginning to the end of a year. Then we can see that. So that's the only confounding factors that I can think of right now in my head.
So we're just waiting for Lamana, and if we have so
Just a minute. Okay. We can lose. Oh.
It's part of the presentation. Good question. Okay.
Testing. Okay, thank you, everyone. So I'm Moses Laman, presenting on behalf of the big COVID-19 sero-prevalence team. There are many people who have contributed to this program of work, and I'm going to present on their behalf. So the sero-prevalence study that the PNGIMR conducted between 2023 and 2025 followed from a number of other program of work that happened prior to that. Slide in a change. And so the main objectives of this sero-prevalence work was to determine the extent of the exposure to SARS-CoV-2 amongst the healthcare workforce, because the healthcare workforce were the major population at risk at that time. A lot of health workers died during the COVID-19 pandemic. They were an high-risk group, and there was also the unknowns about what was happening in the population in terms of the exposure to people within the communities. And so that was an important objective. And the second objective was to determine the trends of exposure through documentation of this through the longitudinal sentinel site surveillance that the Institute was conducting. And this program of work would not have been possible without support from the DFAT host who funded this program or activity through the PAT, PNG Australia Transitional Health Program, who are the managing contractor for this program of work. And the Institute implemented this project with so many support from partners within PNG as well as externally as well. And the team was, the project was, there was an oversteering project steering committee. This was led by Rosheila Dagina from the National Department of Health, National COVID Control Center. And it was composed of people from experts in the field, as well as people from the Austrian ICOM, Nick Harris from Center for Health Security, Professor Leon Robinson, Professor Pomat, Dr. Stella, and a number of people who were part of the steering committee. And the project began on the 15th of March. And within country, there were so many partners who were involved in this program of activities. Particularly, I would like to take this opportunity to thank the provincial health authorities, mainly in Madang, Morobe, West Sepik, and Sydney Central, Western Province, Milne Bay, New Island, Eastern Islands, East New Britain, and Simbu. So as you can see, so many people contributed to this program work. And in terms of the longitudinal sentinel site surveillance, there were sentinel facilities at Mugil, Hola, Baro, Sausi, Buimo, Escape, Lamakot, Karamui, and Kiunga, and many of the major hospitals in those provinces that participated in the sero-surveillance as well. So there was a big team enabling this to happen. So what was the sero-prevalence of COVID-19 at the beginning of the pandemic? As you heard from Dr. Maria Ome, because of the sporadicness of the COVID-19 exposure in the early years of the pandemic, there was not much information available. And so at the time, the government, in the middle of the pandemic, formed the MESAC, Medical Scientific Advisory Committee, to provide advice to the government at the time. And they asked for sero-surveillance to be done. At the time, this was led by Labu, and we supported to enable this sampling of over 12,000 people in 8 provinces. It was within a 1 month period between May and June. In those provinces, you can see on the map there. And when this happened, there were about 307 positives identified, giving an overall proportion of about 2.7% positivity. But there were no better diagnostics available yet in the early days of the pandemic. And the only RDT that was available at the time was a one-step COVID-19 RDT called One Step. And it's later on, studies came after from Doty Institute showed it had a very low sensitivity and specificity ranging at around 60%. And so there was this need to document that was this the real prevalence at the time, documenting this first survey. And so we were fortunate through the STRIVE program, again funded by the DFAT Center for Health Security, we were able to establish the Luminex capacity at the molecular hub that some of the presenters talked about this morning. And this work was led by Daisy, who's in the audience here in Port Moresby, and James Amini as well. And so what the teams found was when they did the sero-prevalence using laboratory assays, the overall prevalence was only 0.72%. So very low, and that was in 2020. And so now, a couple of years later, what do we know about the COVID sero-surveillance? So this is only a summary. I'll come back to talk to it about in the main presentation later, but there was a study now being completed in health workers, in community members who are within the age range of 20 to 40, and community members of all ages, 5 years and above. And there was a second stage of health worker study. And overall, in summary, I would say, as you can see from this table here, the seropositivity rate was above 99%. So the whole country, the pandemic has come and gone through. The full population in PNG has been exposed. And in this study, a number of methods were used. There was a cross-sectional surveys. There were 4 of them. And this will enable us to provide snapshot for the exposure at certain time points throughout the various populations. And there was also ongoing longitudinal surveillance maintained at a number of sentinel sites throughout the country, as supported by many of the PHAs mentioned earlier. And this study was carried out in 3 stages: the health worker survey, surveillance of the high-risk population at the time, because a lot of health workers died. And second stage also included a repeat of health workers, as well as community surveys. And the third stage was the all age groups. And sentinel site surveillance throughout the time continued in those health facilities. So the provinces I've mentioned already participated in this survey, and these were the sentinel sites that participated throughout the country. And there was a lot of work involved: PHA engagement, staff training, community engagement, samples and laboratory testing, and participant consent and information. So in summary, those were the main work that enabled us to determine the COVID seroprevalence in Papua New Guinea, and I'll talk about a part 2 of this in the next. Thank you. No.
We received 3,500 dry blood spot samples from 5 provinces across the country. So Eastern Highlands Province, Madang, Eastern Britain, NCD Central, and Morobe Province. And the serological assay that we used is a multiple bead assay, and this assay measures the exposure to SARS-CoV-2, the virus that causes COVID-19. This serological assay panel was also designed to measure immune responses to other commonly circulating respiratory viruses, such as influenza A and the seasonal human coronaviruses. This study I believe was impactful in terms of preparedness, pandemic preparedness and responses, because this is important for human health and well-being. Sero-surveillance study is important to measure the extent and trend of exposure to a virus like SARS-CoV-2, and data from this sort of study is very important to guide future strategies in pandemic responses and preparedness for a country like Papua New Guinea.
Well, there were many challenges that we experienced during the survey, but I would highlight the major ones that we experienced. So the first one was like when we went to the community, there were ethnic clashes, tribal fights that prevented us from getting in due to safety reasons. So it affected recruitment. And also one of the major challenges that we experienced is when we wanted to go to the PHAs, the director curative and the director public health and the top management people, they were busy, so we had to go and wait until whenever they were available, we met them, and then we went on with the recruitment. And then also COVID was very sensitive, and even the health workers, they were scared. When we went, they didn't want to participate, but we tried our best and we did awareness, and most of the participants, they didn't participate. So it was one of the challenges that we experienced. And also any flight delays that affected our recruitment. Since we had study sites from each provinces, we had to mobilize team from one province to another. So any flight delays, the cost was one of the contributing factors to the delay of the recruitment. The weather, one of the contributing factors to the study. Well, when we went into the community, some of the participants, they were there, and when they heard that we made awareness and we mentioned about COVID, some of them, they ran away, and then some of them, they didn't want to participate, but we explained that this is not to it's not something that will affect you, but it is for the good of the country, for you, your family, and community, and the country as a whole. So yes, COVID is. So we make awareness about the COVID, and then some of the participants that they were willing, they waited until after the awareness, we recruited them. But some of the participants that they didn't want, they left. So it was their right. So we didn't have any rights to force them. So we respected their decision. When we went into the community, some of the participants, they were there. And when
Okay, so regarding stage 2, the sero-surveillance that was conducted by our teams, I'm going to present the preliminary results of this program of work. Yep. So with regards to the healthcare workers, as I mentioned earlier on, they were a high-risk group, but very limited data was available. And so the plan was to investigate in 500 healthcare workers who are providing direct healthcare to people at the time. And so the type of samples done were dried blood spots, and there was a survey on vaccine attitudes and behavior. And the main reasons places that we were conducting these surveys have already been highlighted in the part 1. And there were about 492 out of 500 healthcare workers were enrolled. And as you can see, these were the main variables in terms of the type of cadre of health workers. Most, as we know, the primary health care in Papua New Guinea is provided by nurses, and so the majority of them were nurses and community health workers. And there were health extension officers as well as medical officers, few of them, and others like laboratory, pharmacy, and so forth. And the main facilities for the health worker survey was in 84% of the participants were from main hospitals, health centers, and clinics. Yeah, overall, in terms of the sero-prevalence of the COVID-19, when you look at the healthcare workers, the majority of them again were exposed in this survey. When we look at the vaccinations, it was alarming that a very high proportion of staff were not vaccinated, and it was concerning that when our teams investigated whether they would consider vaccinations again in the future, 73% did not want to be vaccinated. And I think we all know there was a lot of misinformation circulating around at the time, lack of trust, fear of the vaccine. There was some cultural and religious belief as well, and others talked about natural immunity. So those highlight significant public health advocacy that needs to happen in terms of the vaccine, not only for COVID, but other vaccine campaigns, as we see very low coverage in the country at the moment. In terms of the community population between the age range of 20 to 40, in terms of the 20 to 40 age group, these are the mainly mobile population that during the peak of the pandemic were the ones that were becoming first infected, and the concern at the time was to slow the epidemic, was mostly because of this mobile population. And in this group, 2,500 adults were sampled in the selected provinces, and similarly dried blood spots, vaccine attitudes and behaviors were investigated. And these were mainly in NCD Central, Madang, Morobe, East New Britain, and East Sepik. And overall, total participants recruited were over 2,486, and there was a good mix in terms of number of males and females, slightly over, majority were females, and this was mostly in people who are representative of our community in terms of the level of education, and majority of them were subsistence farmers. In terms of vaccination in the adult population, 85%, majority of them at the time of the survey were not vaccinated, and 10% were fully vaccinated, only 10%, 2.4 were partially vaccinated. And this again reflected high rates of misinformation circulating at the time, and over 60% did not want to be vaccinated when you looked at it. And the reasons were very similar to even the health worker group in terms of lack of trust, fear of the vaccine, culture, and religious beliefs. In terms of the third stage of the study, the main aim was to study the exposure in the community of general population. These were those of all ages between 5 and above. And this was conducted in only 2 provinces, in NCD Central and Madang. And they were very similar in terms of their general baseline demography, and not much in terms of vaccination coverage. 90% of them were not vaccinated. Only 7% were fully vaccinated, and 3% were partially vaccinated. And a very significant proportion, 82%, said they would consider getting vaccine in the future. Reasons for those who feared were similar to the other groups. In terms of the longitudinal surveillance happening in all the sites throughout the country, this has been ongoing for a number of years. From 2020 to 2023, this program of work was funded by the Strive PNG project. And from 23 to 25, this was funded by the COVID sero-prevalence grant. And over this period of time, over 12,000 participants were involved in this program of work. And as you can see from this graph of the Sentinel sites over the years where James, Harmony, and Sam were able to pull together, you could see increasing trend of COVID-19 over the years when you looked at it in terms of the number of sero-prevalence positivity rate by those who attended health facilities throughout the country during those periods. And rates were average 86% across all sites. Karamuyu had slightly lower rates of less than 80, it was 73%. And this is probably reflective of the reality that Karamu is a very remote site, and that site will take time in terms of exposure. And that is what's been seen in other countries as well. The more rural you go, the more slower the burnout rate for COVID in terms of exposure to the communities. So what have we learned? Between 2020 and 2024, exposure to COVID-19 came and went from 1% to now more than 99%. The majority of the population has been exposed, although very concerning has been the vaccination rates. This is reflective not only of COVID, but the general vaccines in general. It's been a major concern for the health department and the PHAs and the country as a whole. And from a research perspective, ongoing sentinel site surveillance, not only for COVID, but also all other disease programs will be important for the country. And what does this mean for PNG? What this means, we all can see now for certain with this program of work and data, solid data showing that the population has been exposed. And ongoing exposure in hard-to-reach populations will continue to be a risk for the older group who are yet to be exposed to COVID-19, and those with comorbidities, they're the ones that are at risk still, even at this time. We will continue to need stronger public health advocacy to combat low vaccine rates, and in-country laboratory to enable scalable testing and monitoring remains vital, as we have seen during the pandemic. When everything's shut down, no one is there to help. You will have to look within to find the support, and that was what the PNGIMR was able to provide to support the National Response Program. And so obviously PNG needs ongoing outbreak preparedness. So thank you to the so many partners who have helped us to make this program of work a reality. Thank you.
So my name is Rosheila Dagina, and I was the team lead for COVID-19 surveillance, risk assessment, and response during the COVID-19 period from 2019 till the duration of the pandemic period, and in PNG as well. So apart from that, I'm the chair lady for the sero-prevalence steering committee. So that includes a committee where we have other important partners and technical team that come together to provide the advice. So anyways, with regards to the questions, I mean, we think of many challenges that we face, especially in surveillance. We face the issues of under-reporting, a lot of under-detected cases of many different sorts of infectious diseases, not just infectious diseases, but even the routine diseases that we need to be conducting surveillance on. I see that this study is very important because it actually can help us to map currently now the extension of transmission or the extent of transmission of COVID-19 in the country. And also it looks at the proportion of the population and more around the exposure to the virus, whether the virus has been circulating pre-COVID-19 period, or how does the trend look like? What are the dynamics of transmission that has actually happened over time? So I'm thinking this data is going to be very important, more at the technical level in trying to monitor the epidemiology of the virus, but also at the strategic level, this kind of data should be able to, we should be able to use that to guide public health decision making for future preparedness, knowing where we are, learning from our mistakes, learning what worked well, what didn't work well, and trying to make adjustments as we move forward. So I'm seeing this study that the data can actually help with all levels of response, whether it's at the provincial, national, or even at the international level. We can be able to use this data to inform a lot of decisions around pandemic preparedness, but retrospectively also looking at COVID-19 and the dynamics of the virus in our country.
Hello, my name is Melinda Susapu.
and I was the incident manager during the COVID-19 pandemic from 2020 to 2021. Thank you. So definitely for our presentation that we've gone through, it's always good to have evidence-based information so that if there's policies or if there's strategies, they're based on evidence. And this one was a good one because we had a challenge of having people, didn't want to take vaccines or didn't want to get tested. So this was a good one to highlight to us what the public thought about testing, also about vaccination. So if we have the evidence, we can use the evidence to strategize, also to make policies, to support policies that are in place or upcoming policies in regards to measures.
So, my name is Dr. Ian, and I'm the medical officer currently as the head manager of the Disease Control Communicable Disease at the National Department of Health. But prior to that, I was the incident manager for the NCC for about a year. So reflecting on that question, it's basically the results of that there's a good almost up to about 99% of population, study population is better and it's a good sense of immunity there. And in terms of the future issues and future planning, this shows that there is some degree of immunity, but we left to be very critical in terms of monitoring, ongoing monitoring to monitor all the, especially in the space of the respiratory infections, ILI, so that that will guide future decisions to ensure that whether it be COVID or it be something else, and then other measures in terms of prevention interventions like introducing something like flu vaccines, because it shows that up to about a good number of people, almost like up to 99% of the population study, that indicates that almost most people were actually exposed to some kind of immunity. That really doesn't really tell us, in terms of like the duration and in terms of those actually in terms of the population who are living with maybe any other comorbidities, maybe infected or affected later down the line in terms of worsening. For instance, what the department will do is make sure that there's a surveillance system in place, monitor and ensure that, and beef up the public interventions, make sure that people are taken care of should there be any future.
From this work, I think the key messaging or kind of key information that we hope to guide the National Department of Health was to see how healthcare workers and the community in general were their perceptions of COVID testing as well as the vaccination, because we needed to know if people can have that vaccination to be protected against SARS-CoV-2. And from those findings, we do see there's hesitancy around vaccination, and people are not kind of open to the idea of COVID testing. And so these findings hopefully can guide NDOH to see should there be a surge or pandemic happening, like how do we approach healthcare workers are our key people, and if they are refusing to have vaccination or do COVID testing, then what are the alternative options to work around those? And because we know the communities trust the healthcare worker, so if a healthcare worker is saying, I don't want to take the vaccine, then community are likely to follow. So I guess going forward in preparing for next pandemic or resurgence, we need to kind of see how we can educate our healthcare workers and make sure we are all on the same page and kind of, take our communities forward with how to prevent ourselves against SARS-CoV-2.
Thank you. Thank you for the session, the last session on COVID, and thank you to all the presenters for presenting the data that is available at the moment. I hope you have some questions for Moses and his team. At this point, I have a great question from Nick Harris on how can PNGIMR work strategically and long-term with human, animal, and environmental health and planning agencies in a One Health Planetary Health to research climate impact mitigation and adaptation strategies for better food and nutrition security in most affected areas over the next 20 years and beyond. Thank you, Nick, for this great question. Obviously, it refers back to the One Health session, which Stephan Karl had presented earlier, and the team as well. So it's a great question. I think for the moment, the best strategy that we probably have will be partnership. So we partner across all the different departments that work across all the different agencies and the agencies that not directly involved with health research itself. So the agriculture departments, climate change, the weather people, all of those agencies. I think when we have a secretariat that can, if we have a secretariat that can combine all those agencies together and work in partnership together, I think we can go a long way to ensure that we mitigate the problems that may arise. Because each of us will most likely concentrate only on the areas that we are good at. By combining, by working together, I think we can combine all those areas and have a strategy in place that can help us. And I'm sure we can convince the government of Papua New Guinea to be able to, provide some secretarial support to say, okay, let's work together at national planning to work across all the different agencies that have climate change as a major issue for them. So I think that's the way we'll see it, work, see how food and nutrition will be impacted, how that will impact health, how food and nutrition will impact the environment, that will then impact on health itself. So all of that, I think, comes down back to partnership as the principle by which we work by. So I hope that answers your question, Nick. But otherwise, we can send emails back and forth. Are there any questions for Moses to answer? Or myself, or anyone else for that matter? You have 2 seconds. 1, you've just lost your time slot. So at this juncture, I want to thank everybody who has taken part in this virtual symposium today. Everybody who has prepared slides, who have worked hard over the last few weeks to ensure that their slides were in the right sequences and so on. So thank you very much, everybody. Thank you very much to Webcast Cloud for ensuring that this broadcast was sent to your phone so that you can watch it, to your computers and so on. So thank you, Webcast Cloud team. All the team at the Institute who are working behind the scene. So I know that behind me, there's a whole lot of people who made sure that this event went well, ensured as much as possible to see it run smoothly and to get the questions that you raised to us to be able to answer. We probably haven't answered them all correctly, but we will attempt to do that throughout the next few days. I want to specifically also thank Anne for providing the leadership in ensuring that this virtual symposium went ahead, and the team in our media unit as well for ensuring that the process happened. Thank you to Buttressing Coalition and DFAP for funding it. Otherwise, without funding, we probably won't be here this long. John, do you have any last words to say?
No, just great session. Yeah, all the same acknowledgements as you just made. Great to see the work at the IMR, and thanks Anne and Willie and Gwendalyn and everyone. And Moses. and look forward to more of the same. Thanks very much.
All right. Thank you. Thank you, everybody, for your time and your energy in making sure that this symposium was successful. Thank you, True.